I think as people slowly get back to their seats, we will go ahead and invite Dr. Bennett to make her way up to the podium. And we'll open the afternoon session with the pneumococcal conjugate vaccine.
Thank you, Dr. Temte with a T, and good afternoon. It's my pleasure to introduce the pneumococcal vaccine session to you today. First, I'd like to, thank you very much. First, I'd like to thank my committee. Which should I use the pointer? Is that, sorry. Yeah. First, I'd like to thank our work group. We are lucky enough to have two new members, Art Reingold and Allie Kemp. We also particularly wanted to thank Matt Moore and Cindy Whitney for standing in for the last couple of weeks so that we could continue our progress. But we're very happy to have tomorrow back, needless to say. Just to review the terms of reference, that is the purpose of the pneumococcal work group. One is to review current data on efficacy, effectiveness, immunogenicity, and cost effectiveness. Another is to review current recommendations, considering up-to-date evidence. And as you know, the evidence changes all the time, including epidemiologic studies and assessing the strength of the evidence. And the third is most important for today's discussion, and that is to revise or update recommendations for pneumococcal vaccine use as needed. And really what we're here today is to ask you whether or not this is an appropriate time to review the routine infant immunization schedule for pneumococcal conjugate vaccine 13. So those are the questions that we're going to address ourselves to today. However, first I wanted to just briefly review some of the pneumococcal workgroup activities over the last 3 years. In February of 2010, PCV 13 was licensed. This replaced PCV 7, and as a result, we also developed routine recommendations for infants and children, and permissive recommendations for 6 to 18-year-olds with immunocompromising conditions. In December of 2011, PCV 13 was licensed for adults older than or equal to 50 years of age. At the February meeting that year, 2012, we deferred routine recommendations for adults for two reasons. One was to wait for the results of the CAPITA trial, which we are still awaiting, as you know. And second was to be able to observe the indirect effects of immunizing children with PCV 13. In June of 2012, we made recommendations for the use of PCV 13 in adults with immunocompromising conditions. And then in January of 2013, PCV was licensed for children 6 to 17 years old. And at that point, we made recommendations at the February meeting for 6 to 18-year-olds with immunocompromising conditions, thus harmonizing the adult and childhood recommendations. So for today, we are really in a different era. Pneumococcal conjugate vaccines have been used in the US for 12 years. And as you know, it's been on a 4-dose schedule, 2 months, 4 months, 6 months, and somewhere between 12 and 15 months of age. The use of PCV7 has led to reductions in otitis media and large reductions in invasive pneumococcal disease and pneumonia in children and adults. We are now confronting increasing evidence that is emerging supporting a 3-dose PCV schedule. There have been several randomized controlled trials evaluating the efficacy and immunogenicity of a 3-dose schedule, and in addition, observational studies have looked at the impact. There are at least 34 high or upper middle income countries that have adopted a 3-dose schedule, either with PCV 13 or PCV 10. Some of those countries have gone from a 4-dose schedule to a 3-dose schedule. So the objective for today's session is not to discuss our policy direction specifically, but rather to look at the information that's available about PCV 13 on a 3-dose schedule, and to review that evidence and discuss considerations for including a 3-dose schedule in the routine childhood schedule for PCV 13. We have 2 specific questions for the committee that we are posing today. One is the evidence adequate to consider including a 3-dose PCV 13 schedule for infants? And secondly, if not, what additional data or information would be required for the committee? This will give direction to the work group in how we should move forward in considering a 3-dose schedule in the United States. So today we have 3 presentations. The first is an update on the indirect and direct effects and vaccine effectiveness of PCV 13, and Matt Moore will give that. Secondly, Tamara Pilishvili will report and share with you all of the data that the work group has reviewed regarding reduced dose schedules for PCV 13 for children. And then lastly, Charles Stoecker will discuss cost effectiveness of PCV 13 reduced dose schedules. Thank you so much, and we hope that you will contribute to this discussion and give the work group good direction. So first we're going to hear from Dr. Moore.
Thank you very much, Dr. Bennett, and thanks very much to the committee for the opportunity. I'm really excited to be able to provide you with this update on the impact of PCV 13 use in the U.S. Dr. Bennett just went over a lot of this, and so I'm not going to belabor it. As she said, PCV 13 was licensed in the U.S. in February 2010. That licensure was based primarily on non-inferior immunogenicity against serotypes that were common to both PCV 13 and PCV 7. And there were no randomized controlled trials with clinical endpoints as a condition for licensure. ACIP recommended use of PCV 13 in February 2010 on the 4-dose schedule. And infants who started the schedule with PCV 7 were recommended to complete the schedule with PCV 13. Serotype catch-up is something that was implemented for children who had already been fully vaccinated with 7-valent vaccine, so they were able to receive a dose of PCV 13 so that they would have some protection against those additional serotypes included in the vaccine. And as of the end of 2012, we know from the National Immunization Survey that coverage among 19 to 35-month-olds is about 92% with 3 or more doses and about 82% with 4 doses. So in this context, we wanted to think through all of the different ways that we could look at the impact of the vaccine on invasive pneumococcal disease. And CDC monitors invasive pneumococcal disease, or IPD, using active population-based surveillance in 10 areas around the US as part of our active bacterial core surveillance, or ABCs program. So we, as I mentioned, looked at this in a few ways. We evaluated cumulative counts of IPD, which I'll show you in a moment. We've also undertaken some modeling exercises, which I've presented very briefly at this meeting in the past. And then we've also been conducting a case control study of vaccine effectiveness among children who are eligible to receive the vaccine. And I'll be sharing those results for the very first time at this meeting today. So this is a line graph showing on the y-axis the cumulative numbers of cases of invasive pneumococcal disease among children under the age of 5. And if you look at the title, you'll see that it says PCV5. PCV5 is not a new vaccine. It's not a vaccine that we're using. What it is it's those serotypes which are uniquely affected by the 13-valent vaccine, which are not affected by the 7-valent vaccine. Now, I know that 13 minus 7 equals 6 and not 5. But it's 5 serotypes because one of the serotypes in PCV7, that is the serotype 6b antigen, actually has substantial cross-protection against a serotype that's also in the 13-valent vaccine. So again, these are the 5 serotypes that are uniquely affected by this new vaccine. We wanted to look at the incremental benefit of this vaccine over and above what's already available and what we already know about the 7-valent vaccine. Pneumococcal disease is a very seasonal disease, and if you follow the pink line here, or I guess it's a dark purple line on the screen, you'll see that disease increases fairly quickly over the winter months, and then it flattens out over the summer months. And then look what happened in 2010. It flattened out again, whereas in previous years it had increased substantially. So this was the first indication we had that PCV13 was having an impact on these particular serotypes. It becomes much more dramatic in 2011. You can see that green line is quite a bit below all of the other lines, and then continues in 2012. And even in 2013, we have good data through the first quarter of 2013, and we're working to update this as quickly as possible. So this really suggests to us that we're seeing direct impact of the vaccine on invasive pneumococcal disease in children who are recommended to receive it. But because of the experience with PCV7, we were also very interested to know whether or not the vaccine is interrupting transmission from children to adults. So that's what's shown in this slide. It's formatted exactly the same way, and I'm focusing here just on adults 65 and over, and showing you that we have the same seasonality of pneumococcal disease in adults, where disease accumulates fairly rapidly over the wintertime, flattens out over the summer, and then begins again in the late fall and early winter. And you can see perhaps a suggestion in the latter part of 2011 by that green line that maybe things were starting to drop off, but it's very obvious in 2012 that rates of disease were declining then, and we're continuing to see that same pattern into 2013. So very, very exciting that the vaccine is working as expected at a population level. We decided that we wanted to try to estimate exactly how much disease has been prevented, both in terms of reductions in incidence as well as number of cases prevented. And these data come from our active bacterial course surveillance program, and so we decided to try to model it. This is a very scary graph, but don't be scared. I'll walk you through it slowly. On the y-axis here are numbers of cases that we observe on a monthly basis in ABCs. And that's what this blue line with the little blue dots are showing you. Those are actual numbers of cases that we observed during each month up until vaccine introduction. Then what we did is we developed a time series model demonstrated by the dark black line that attempted to mimic that. And you can see that those 5 serotypes that are uniquely affected by PCV13 were actually increasing in incidence before vaccine introduction. And so if we continue that time series model out past the period of vaccine introduction, which is indicated by this vertical black line, this is where we would have been in the absence of PCV13. But instead, what we actually saw was this dramatic drop-off indicated by this dark blue line, indicating that the number of cases of disease caused by those additional serotypes had declined dramatically compared to what we would have expected in the absence of vaccine. And if we do a calculation on this, we would estimate that that was an 88% reduction in invasive disease caused by these serotypes in this population during the second year after vaccine introduction. We can do the same thing for adults 65 and over, and that's what's shown here. Similar sort of idea. The black line represents the modeled incidence of disease, and then after vaccine introduction, you can see the dark blue line drops off, and that constitutes approximately a 47% reduction in that second year after vaccine introduction compared to where we would have been in the absence of vaccine. So if we repeat this exercise for all of the different age groups, we come up with a table like this. And we can see a couple of things. One is that we've got statistically significant reductions in invasive disease in all age groups, actually in the very first year after vaccine introduction. So quite a dramatic indirect effect of vaccination. The other thing that you can see is that the reductions in the second year are uniformly a little bit bigger than what we observed in the first year. So things are getting better with each year of vaccination. We're working to update these data so that we can include data from July of 2012 through June of 2013, and we hope to be able to share that with you at a future meeting. So the next thing we wanted to do was figure out, well, how many cases of disease and how many deaths have actually been prevented as a result of vaccine introduction. And so we took these data which are largely based on our surveillance in 10 areas around the country, and we projected to the rest of the country based on what we know about the age and race distribution of the country. And we believe that about 20,000 cases, or actually a little bit more than 20,000 cases, have been prevented since vaccine introduction. And not surprisingly, a large number of them are in children under the age of 5 who should be getting the vaccine. But actually, we're also seeing substantial prevention in those who are mostly not recommended to receive this vaccine at all. Very few children die of invasive pneumococcal disease. Most of the deaths that occur are in adults. And so it's not surprising that when we look at the deaths prevented, the vast majority of those are in adults. So this blue sliver here is children, and then these larger slices of the pie are all adults 18 and over. So very, very promising results showing that a lot of disease is being prevented. We were also interested in knowing how well is the vaccine working at the individual level, and so I'm sharing with you very preliminary results from a case control study of PCV13 effectiveness. This is a study where we look for cases of invasive pneumococcal disease using our routine surveillance among children 2 to 59 months old who are residing in any of those 10 ABCs areas. And for the purposes of this study, we've expanded it to include New York City, Los Angeles County, and the state of Utah. We attempt to enroll 4 controls for every case, matched on age and zip code. And I'm sharing with you results up through May of this year. As of May of this year, we've enrolled 765 cases. About 29% of those had PCV13 type IPD, and about 93% were caused by serotypes 19A, 7F, and 3. So that gives you an idea that the majority of PCV13 type disease is actually caused by those 3 serotypes. We've also enrolled 2,274 controls, so that's about 3 controls for every case. And when we look at receipt of at least 1 dose of PCV13 during the first part of the study from June to November of 2010 and compare that to December 2012 through May of 2013, we see that coverage with at least 1 dose has increased from 37% to 96%. So at least among this control population, uptake appears to be very good. So this table then shows you what we're observing in terms of the different outcomes. The top row represents vaccine effectiveness against all IPD of about 65%. With 95% confidence intervals that do not overlap 0, so a statistically significant result. And if we just look at those serotypes that are included in the vaccine effectiveness with 1 or more doses is 89%. If we focus just on those 3 serotypes, 19A, 7F, and 3 as a group, we get actually an identical result. And that's simply a reflection of the fact that we have very, very little disease caused by serotypes 1 or serotype 5 or serotype 6A, those 3 additional serotypes that are in PCV13 but not in PCV7. So most of these results are being driven by these 3 serotypes. And then if we drop serotype 3 out of the evaluation, because compared to 19A and 7F, we actually have relatively little serotype 3. It's a lot more than serotype 1 or serotype 5. We see, again, a very, very good result, 93% vaccine effectiveness of 1 or more doses. So in summary, we have observed 89% effectiveness of at least 1 dose of PCV13 against PCV13 type invasive disease, an 88% reduction in IPD caused by those serotypes that are uniquely affected by this vaccine in children, and then a 47% reduction in disease among adults 65 and over 20,000 cases and over 2,000 deaths prevented based on our estimates. So PCV13 appears to be highly effective at preventing IPD among kids who receive the vaccine, and we're also seeing substantial indirect effects within these first 3 years after vaccine introduction. So I'd like to acknowledge the many, it's not working now. Can you advance 1 slide for me? Thanks. Acknowledge the many people in our ABCs areas, as well as New York City, LA County, and Utah who've been helping us with this work. And with Dr. Temte's approval, I'll be happy to take any questions.
Yes, we're open for questions for Dr. Moore. Yeah, Dr. Dushin.
Thanks. That was a great presentation, and I haven't kept up with the literature on this, but I'm wondering if you can remind me if there have been studies that look at in individual cases the emergence of strains that have undergone either capsular transformation or capsular switching with non-vaccine serotypes emerging with, the basic genes of an old 3 or 19A strain or something
Sure.
like this. And I know that doesn't imply that would become a population-wide problem, but I'm just curious.
Right, so a couple of issues in there. One is the broad issue of serotype replacement, and that is, are we seeing increases in invasive disease caused by serotypes not included in the vaccine? The answer up to this point is no, we're not. And we don't know if we're going to see that or when we're going to see it, but we're certainly using our surveillance to monitor for that. The issue of capsular switching, whereby a particular serotype, say a 19A, loses the genetic material for a 19A capsule and takes on genetic material for a different serotype, say 35B or 11A. When it's clear that did happen during the PCV7 era, but it played a relatively minor role in the overall serotype replacement story. It seemed that what was happening with serotype replacement is that those serotypes that were common before vaccine introduction were the ones that were most likely to become replacing serotypes. And although capsular switching happened, it was comparatively an uncommon event.
Dr. Vasquez.
Can you comment on specific types of invasive pneumococcal disease with PCV7? There seemed to be an upsurgence of empyemas. Of all your invasive cases, are the majority of them pneumonias, bacteremias, and do we know anything about the number of cases of empyema since the routine use of PCV13?
Yeah, good question. So we haven't looked specifically at empyema in the PCV13 era. In our data during the PCV7 era, we actually didn't see a substantial increase in empyema. And I don't know whether that was related to perhaps something different about the local epidemiology in other places where that was observed. For example, in Utah, serotype 1 increased after PCV7 introduction and was associated with empyema. Interestingly, serotype 1 empyema started going away in Utah before PCV13 was introduced. So we did not see a lot of empyema during the PCV era in our data, and we haven't looked yet during the PCV13 era, but we can certainly do that and report back at a future meeting.
Dr. Harrison.
Yeah, Matt, can you comment on remaining disease burden due to PCV13 serotypes in adults?
Right, so I think what you're asking is sort of what proportion of remaining invasive disease is caused by PCV13 serotypes in adults? Yeah, so the numbers of cases are kind of alluded to here, not this one, but this one. So if you look at adults 65 and over, we've had less than 100 cases of these additional serotypes as of this point in 2013. If you want to take 2012 as a marker, we had maybe 175, and if you want to do a rough approximation and say that this is roughly 10% of the US population, you could multiply that by a factor of 10. As a proportion of all disease, I haven't looked very, very recently, but I can tell you that before vaccine introduction, those PCV13 serotypes as a group caused about 45% of disease in adults, and we've already seen a 50% reduction. So that gives you a ballpark that maybe we're down in the 20% range right now.
Dr. Jenkins?
I don't think you asked this or answered this yet. So this is representing about how much uptake of the vaccine. I know we have, challenges in getting a percentage of the population vaccinated. So this reflects, what do you think the uptake rates are?
Sure. So we have two estimates for that. One comes from the National Immunization Survey here, and these are the data that are as far as I know, the most up-to-date data that are posted on the NIS website now. So about 92% of children had received adults, I'm sorry. Very, very good question. Thanks for asking. Sorry that I misunderstood you. So remember that PCV13 was licensed for adults in 2011, and the subsequent ACIP recommendations were only for immunocompromised adults, which is a pretty small proportion of the total. So at the moment, we actually don't know how much uptake we have in adults. We would expect that this would reflect primarily indirect effects of vaccinating children, because we know that uptake has been so high in children, and most of this effect happened before PCV13 was even, or a good part of this happened before PCV13 was even licensed for adults, let alone being recommended for just the population of immunocompromised adults.
Dr. Bocchini.
I wanted to ask, amongst the children who developed invasive disease, do we have enough data to look at epidemiologic features, risk factors?
Yeah, good question. So as part of our vaccine effectiveness study, we also have a risk factor study embedded in there, so we will be looking at risk factors. What I can tell you is historically within ABCs, it's been a relatively small proportion of all of our cases among children who have underlying conditions. And I'd say a relatively small proportion, on the order of about 10%. So 90% of disease is in healthy children.
Well, would you also look at daycare center attendance and socioeconomic group and things like that?
In our routine surveillance data, we don't capture that kind of information, but in the case control study, we are capturing information on daycare attendance, underlying conditions, administration of other vaccines, all of those sorts of issues, and we also are asking about socioeconomic status.
I think if we're going to define who's at high risk and who's not, I think those are going to be things to consider in making decisions.
Yeah.
Dr. Sun.
Matt, do you have data on for the pediatric rates of cases? How many of those received 3 doses versus 4 doses?
Yeah, so from the case control study, I appreciate Dr. Sun asking the question. One of the biggest challenges we've had is being very, very clear about which children received the 7-valent vaccine and which received the 13-valent vaccine, because we had that transition period where both were available. And so we're working really hard to get information on 1 versus 2 versus 3 versus 4 doses, but we just don't have enough of that finalized at this point that we actually haven't done that analysis yet. That's why I didn't present it today, but it absolutely is an important part of the ultimate analysis that we're going to do for the case control study.
And Dr. Whitley-Williams.
Yes, Pat Whitley-Williams from the NMA. When you look at the data broken down by ethnicity, are you seeing the same impact? And I'm actually more interested if you see any impact in the adult population given the lower immunization rates.
So let me make sure I understand your question. It sounds like there are 2 in there. One is for children. Are we seeing a change in rates or any difference in rates based on race or ethnicity? But I don't think I quite understood your question about adults.
In other words, looking at the same data, if you break it down by ethnicity, are you seeing the same sort of indirect effect on the adults in the different ethnic groups?
Yeah, okay, good question. So for PCV13, we have not looked yet. We've been focusing on sort of everything as an aggregate. What I can tell you from our experience with the 7-valent vaccine is that there were substantial disparities in invasive pneumococcal disease between African Americans and whites, and PCV7 essentially eliminated the disparity in the disease caused by the vaccine serotypes, but did not obviously eliminate the disparity caused by the other serotypes. There's still a remaining disparity there, both for children and for adults.
And also in the Native American and Eskimo population, particularly where certain serotypes are a major issue.
Yeah, that's. I don't have those data available, but we could certainly try to bring them for a future meeting. You're absolutely right that it's been a big issue. What we've been hearing from our colleagues is that they're seeing similar sorts of effects of the vaccine in those populations.
Any comment by Ms. Groom?
Yes, thanks. I was going to wait till the end of the presentations to bring this up, but the Indian Health Service is really interested in any information the working group might have or something they could look at regarding the specific impact of reducing the series for the American Indian Alaska Native population because of the higher background rates, both pre-vaccine and post-vaccine, that we continue to see in certain geographic regions. So we'd be very interested in the working group taking a look at that.
Sure, we'd be happy to work with you.
Dr. Brady.
Yep. Two questions. One is, there was a difference between the proportion who'd received 3 doses versus 4 doses. And the ones that received only 3 doses, which dose was primarily missed?
Could I ask you to be patient, because that is going to come up in the very next presentation.
The second
We've got those
one,
exact data for you.
There was kind of a unique pattern that in the middle of each large bump in the children, there was a significant decline. Is that related to the Christmas holidays?
So do you mean the sort of notch here?
Yeah, the notch.
Yeah, that's a good question. I don't think I have a good answer.
It happens every time.
It does happen every time. I mean, what's interesting is that what we used to see here was, if you see this little tiny peak, it used to be a much, much bigger spike. And we saw that year after year, and it was literally the week between Christmas and New Year's, and that went away after PCV7 was introduced. So definitely the vaccine has a way of affecting the peaks and the troughs, if you will.
If it's at all helpful, we have a manuscript in preparation looking at all-cause respiratory infections in a very large primary care population. And with the Christmas holiday, you get a substantial drop-off
Right. That's what I
that
was
pops
assuming.
back up after. I think at this point we can move on to Dr. Pilishvili and presenting on the reduced dose schedule review of the evidence.
Good afternoon, everyone. I thank you, the committee, for giving us the time to present this data, and also glad to be back after a long break. So as Dr. Bennett outlined our session, this presentation is the bulk of our session, and we will be reviewing considerations for a 3-dose PCV13 schedule for infants, mostly focusing on the evidence that was reviewed by the work group during the preceding few months. So the question is, what is the rationale for the work group discussing this topic? And as Dr. Bennett explained earlier in the session, the evidence supporting the use of 3-dose PCV schedules has been emerging. And a 3-dose schedule, PCV13 schedule, is approved by EMEA. Recently, WHO published a position statement in which it makes it clear that it recognizes a 3-dose schedule as an acceptable alternative to a 4-dose schedule. At least 34 countries, and of these 21 were high-income countries and 13 were upper-middle-income countries, have introduced either PCV13 or PCV10 with 3 doses, and some of these have switched from a 4-dose schedule to a 3-dose schedule. As you saw in a previous presentation, and as you already know, PCV7 use in this country has led to dramatic reductions in disease burden. We observed reductions in invasive pneumococcal disease and pneumonia in children and adults, and reductions in otitis media in children. PCV7 serotypes have virtually been eliminated from all age groups as causes of disease. And as you saw in a previous presentation, disease due to serotypes that are in PCV13 and not in a PCV7 have also been rapidly declining. US has now a mature PCV program, which means that we've had high coverage and stable rates for many years already. And it's a very, in the country, there's a high acceptability of this vaccine. So the question comes to mind is, can a 3-dose PCV13 schedule be introduced into a routine schedule for infants in this country? There are many factors that need to be considered when deciding on whether a policy change is warranted. First and foremost, does the available evidence support the change? And as I mentioned earlier, today's presentation will focus largely on the review of this evidence and the evidence that has been reviewed by the work group. The work group also considered other considerations that are listed here, such as safety, policy, statute considerations, economic considerations, programmatic considerations, and there have been discussions on the work group calls raising issues related to each of these considerations. However, in today's presentation, I will only briefly touch on these. We welcome the committee to comment on the issues that we should keep in mind in our future discussions. However, we would like to defer these comments until we've had a chance to have a discussion on the evidence. In reviewing the available evidence for 3-dose PCV infant schedules, we focused on studies which evaluated schedules with 2 doses in a primary series, followed by a booster dose in the second year of life, and we will refer to this schedule as 2+1, and a schedule with 3 doses in the primary series without a booster in the second year of life, and we will refer to this schedule as a 3+0 schedule. We reviewed evidence from randomized controlled trials evaluating efficacy of PCV. We also reviewed effectiveness studies, such as case control studies or indirect cohort analysis, ecological studies that document the impact of the PCV introduction on a reduced schedule from other settings, and breakthrough cases. And during the upcoming slides that I will be showing, we'll focus on a review of evidence for each of the outcomes listed here for invasive pneumococcal disease, or IPD, pneumonia, acute otitis media. We'll also present evidence on indirect herd effects of the reduced schedules, results of the carriage studies, and immunogenicity studies. Results of 5 randomized controlled trials evaluating efficacy of PCV schedule against IPD are summarized on this slide. A study in Finland, this is the most recent one, evaluated efficacy of 10-valent conjugate vaccine, PCV10, of 2+1 schedule and a 3+1 schedule, which is 3 doses in a primary series followed by a booster, which is a schedule used in this country. This study was not powered to make direct comparisons between these 2 schedules. However, the efficacy compared to no vaccination was reported for 2+1 at 92% and for 3+1 at 100%. 2 trials of 9-valent conjugate vaccine, PCV9, using a 3+0 schedule, one from South Africa and one from Gambia, reported 83% and 71% efficacy. As a comparison, 2 trials in the US using PCV7 on a 3+1 schedule, one in the general population of US infants and one in the Navajo population, reported efficacy of 94 and 83%. 3 case control studies and 3 studies using indirect cohort method evaluated effectiveness of various schedules of PCV. Effectiveness following 2 infant doses ranged from 70% to 99%, and this was reported from 5 different studies. The effectiveness of 2+1, 3+0, and 3+1 were very similar and ranged from 77 to 100%. None of these studies were designed to make direct comparisons between schedules. Surveillance studies conducted in 7 countries describing the impact of national PCV introduction on vaccine type IPD among young children are summarized on this graph. The impact is measured as % reduction in vaccine type invasive pneumococcal disease among young children. Although surveillance methods varied and each study only reported the impact of one particular PCV dosing schedule, some general comparisons between the schedules can be made. One similarity was observed among nearly all studies was the significant impact of PCV introduction on vaccine type invasive disease over time in populations that have used different schedules, 2+1, 3+0, or 3+1. And these effects were seen as soon as 1 to 2 years post-vaccine introduction. And another general trend that is pronounced is that reductions, the largest reductions for all schedules were seen 3 or more years post-introduction, and these are studies that are presented in green bars compared to less than 3 years post-vaccine introduction, and these are studies that are summarized with blue bars. So to summarize the findings for invasive pneumococcal disease, both controlled trials and observational studies demonstrate that the schedules, both three-dose schedules, 3+0 and 2+1, are highly effective against invasive pneumococcal disease. And there are no studies that directly compare 3-dose schedules to a 4-dose schedule. Next, I will summarize studies evaluating effect of PCV schedules on pneumonia. Results of a systematic review of randomized controlled trials published from 1994 to 2011 documenting the efficacy of PCV dosing schedules on clinical and radiologically confirmed pneumonia are presented here. 3 studies evaluated efficacy of 3+0 schedule, and 2 of these showed efficacy against clinical or radiologically confirmed pneumonia. The clinical trial in Philippines by Lucero and colleagues showed impact of 11-valent vaccine on radiologically confirmed pneumonia, but not on clinical pneumonia. 3 clinical studies evaluated efficacy of 3+1 schedule against pneumonia. All clinical trials showed evidence of PCV benefit on clinical and radiologically confirmed pneumonia. However, one German study had a confidence interval that was overlapping the null, and this was a non-randomized single-blind clinical trial, so this limits the interpretation of the findings from this study. 4 observational studies evaluated effectiveness of 2+1 PCV schedule on pneumonia. 2 of these are presented on this slide. A study from Italy by Ansaldi and colleagues showed significant reductions in hospitalization rates for all-cause and pneumococcal pneumonia. And the study was conducted based on discharge diagnosis that were observed in subjects born after widespread uptake of the vaccine. Percent reductions, which is like a measure of vaccine effectiveness, ranged from 15% for all-cause pneumonia to 70% for pneumococcal pneumonia. The second study by Esposito was a retrospective cohort evaluating impact of PCV7 on radiologically confirmed pneumonia. Parents participating in this study could choose whether or not to have their children vaccinated, and providers and parents were not blinded to the intervention. The effectiveness reported in the study was somewhat higher compared to other observational studies, as well as compared to clinical trials. The graph in the upper left corner presents the analysis from Quebec. Quebec introduced PCV7 first for high-risk children in 2002, and then on a 2+1 schedule, it introduced routinely for all children in 2004. The study here examines the hospital discharge records by analyzing monthly frequencies in the diagnosis of pneumonia. Overall hospitalization for all-cause pneumonia decreased steadily during the period from 2004 through 2006, and beginning with the routine implementation of the PCV7 program on a 2+1 schedule, there was a sudden decrease in the frequency of lobar pneumonia observed. And that continued up to the end of the study, and at the same time, there was an increase noticed in the frequency of unspecified pneumonia. A study from Poland by Patrozalik presents the number of hospitalized pneumonia cases per 1,000 children in the 2 years preceding vaccination, 2004 and 2005, and 2 subsequent years, 2007 and 2008. After implementation of the vaccination program, significant reductions in the incidence rates in post-vaccine years for children in the first year of life and those 2 to 4 years old of 65% and 23% were reported. In Australia, where a 3+0 PCV7 program began in January 2005 for the general population of children, analysis of monthly hospitalization rates for all-cause pneumonia showed a statistically significant decrease in rates in the period following vaccine introduction. After adjusting for background trends and seasonal cycle, a reduction of 38% was observed for all-cause pneumonia among children aged less than 2 years. One observational study directly compared the impact of 2 versus 3 primary PCV doses against clinical pneumonia incidence, and this was in a general pediatric population for a 2002 birth cohort. This was a propensity score matched case cohort study conducted in the US and evaluated rate of hospitalizations and ambulatory visits for pneumonia. Comparisons between schedules with 2 and 3 doses in the primary series before the booster dose are shown on the left side graph and after the booster dose on the right side. The study found that children who received 3 doses in the primary series had fewer ambulatory visits and hospitalizations up to the point of the receipt of the booster dose. And this resulted in a rate difference of 7.8 cases per 1,000 children, and this was a significant finding. However, the difference disappeared after a booster dose was administered. In addition, the study investigators repeated the analysis for the 2003 birth cohort, and the same findings of the differences in rates between the two schedules were not observed for the 2003 birth cohort, where there were 4 per 1,000 more pneumonia admissions for 3-dose primary schedule versus 2-dose primary schedule, and no significant differences were observed. And the study investigators, they hypothesized that this finding was due to the fact that with an additional year of using the vaccine in a target population, the coverage has gone up, the herd effects took place, and because of that, the differences that were observed in rates of disease between children in these 2 groups were minimized. To summarize findings for the pneumonia outcome, schedules with 3 PCV doses, both 2+1 and 3+0, prevent pneumonia. There's one observational study that showed that the 3-dose primary series are better than a 2-dose primary series before the booster dose. However, no differences were observed after the booster dose or for the later cohorts. And a schedule with 4 doses may be more beneficial early post-vaccine introduction. So next I will proceed with reviewing the evidence for the outcome of acute otitis media. There are no randomized controlled trials evaluating efficacy of 3-dose schedule against otitis media. Results of observational studies evaluating effectiveness of 2+1 schedule are presented in this table. The effectiveness estimates ranged from 13% to 36% from these 3 studies. Monthly incidence of acute otitis media in children born in 2002 who received 2 or 3 doses in the primary PCV7 series was compared using propensity score matching using data from the insurance claims database. The study assessed acute otitis media rates after completion of the primary series and before the booster dose. This is a figure on the left, and after the booster dose until 4 years of age, figure on the right. Results showed that the pre-booster dose incidence rates were 0.38 per person for children receiving 2-dose primary series and 0.35 per person for those receiving 3-dose series. And these differences in rates were not statistically different. Post-booster incidence rates were also very similar, and there was no statistical difference observed between the 2. To summarize the findings for acute otitis media, we have no clinical efficacy data for 3-dose schedules. Data from observational studies show that reduction in acute otitis media following PCV7 introduction is observed on a 2+1 skewed schedule, and there's no significant difference in acute otitis media incidence for 2+1 versus 3+1 before or after a booster dose. So there's a large body of evidence from immunogenicity studies on various 3-dose schedules. And you have 3 slides in your handouts that present the results of meta-analyses and the systematic review of immunogenicity studies that compare the schedules with 2 and 3 dose primary series with and without the booster. So as you can look in your handouts, those are pretty dense forest plots, which I will spare you, and I will not walk you through those forest plots, but instead of doing that, I will summarize the main key points from these studies on this slide. Geometric mean antibody concentrations, GMCs, and proportion of subjects over 0.35 micrograms per mil, which is the reference point for antibody levels post-primary series, and it was developed for invasive disease. So this endpoint was analyzed in most of the immunogenicity studies that were part of the meta-analysis and part of the systematic review, and the studies show that the proportion greater than 0.35 is high for both schedules with 2 and 3 primary series. The post-primary doses, the 3-dose schedule appears to result in overall higher antibody levels compared to the 2-dose schedule for some or most serotypes, depending on the study. However, in the second year of life, both pre-booster and post-booster dose, little to no difference is observed between the 2 schedules. With 3-dose and 2-dose primary series. However, there are small but significant differences observed for 2 serotypes, 6B and 23F. Recently published results of a randomized clinical trial of PCV13 report immunogenicity for 4 different schedules. In this study, 400 infants were randomly assigned to receive PCV13 either on a schedule with 2 different schedules with 3 primary series, which is at 2, 4, and 6 months, and at 2, 3, and 4 months. And 2 of the schedules with 2 primary series were at 2 and 4 months and at 3 and 5 months. And then for all of these children, a booster dose was given at 11.5 months. Antibody geometric mean concentrations against PCV13 serotypes were measured 1 month after a booster dose and 1 month after the primary series. And the responses at different time points between all these schedules were compared in a study. However, on this slide, when I review the results, I will focus only on 2 comparisons that are relevant for the immunization schedule in this country. And that is a schedule with 3-dose primary series at 2, 4, and 6 months, and 2-dose primary series at 2 and 4 months. So comparisons relevant to the US schedule were as follows. Post-primary series, 2, 4, and 6 month primary schedule was better than a schedule with 2 primary series at 2 and 4 months for 11 serotypes. Post-booster, schedule with 2, 4, and 6 month primary series was better than a schedule with 2 primary series for only 3 serotypes. And some of these other differences, they disappeared after a booster dose. So the 3 serotypes are 6B, 18C, and 23F. So in a way, the study confirmed the findings of the large meta-analysis that are included in your slides. However, there's the difference before post-primary series was observed for a larger number of serotypes in this study compared to the meta-analysis, and also for the 2-dose primary series schedule, the antibody levels were lower compared to other studies for some serotypes. However, this is a very recent study. The work group hasn't had a chance to discuss it, and they use a different laboratory method. They use a bead assay instead of an ELISA. So we have not really fully reviewed the results to understand whether that contributes to some of the differences observed. So to summarize the findings of immunogenicity studies, both 3+0 and 2+1 schedules induce good antibody response. After primary series, geometric mean concentrations may be higher for schedules with 3 doses in primary series compared to 2 doses in a primary series, but the difference is no longer apparent in the second year of life, even before the booster dose. After the booster dose, the difference between the schedules are only seen for 2 serotypes from most of the studies and from meta-analysis reported, and for 3 serotypes in a recently published immunogenicity trial. However, it is important to point out that the immunogenicity studies we reviewed were conducted outside of the national immunization program. So in these settings, in the underlying population, no herd effects have been observed. In addition, the GMC cutoff of 0.35 micrograms per mil that I mentioned as a reference point that is being used to interpret the immunogenicity results should be interpreted with caution, because it's an aggregate cutoff which was developed for all serotypes and may not be applied to individual serotypes. In addition, this was a reference point for the antibody levels post-primary series. So for post-booster dose, it may not have the same meaning. And also the significance of this cutoff for endpoints other than invasive disease is not clear. Next, we'll review evidence for PCV effects on nasopharyngeal carriage. 2 clinical trials in Fiji and Gambia with direct comparisons of schedules with 2 or 3 primary series are presented here. A study by Russell et al. Compared carriage of vaccine types at different time intervals following the administration of 0, 1, 2, or 3 doses of PCV, and showed that percent vaccine type carriage was lower overall for schedules with 3-dose primary series. However, significantly less vaccine type carriage in 3-dose group versus 2-dose group was observed only at 9 months of age, and no statistical differences were observed at 6, 12, or 17 months of age. In study by ADA, infants were assigned randomly to receive 1, 2, or 3 doses of PCV between 2 and 4 months of age. The results show that at 11 months, the 3-dose group, presented here with dark gray bars, showed a borderline significant reduction in vaccine type carriage compared to 2-dose group. And there are differences observed at 5 months and 15 months, but these were not statistically significant. Two clinical trials conducted in Israel and Netherlands with direct comparisons of schedules with 2 or 3 primary series, and the effect of the booster dose was evaluated in the studies presented here. A study by Dagan and colleagues showed that pre-booster at 7 to 12 months of age, carriage rates for all PCV7 types were non-significantly lower in the 3+1 group as compared to the 2+1 group. These differences, when examined by individual serotypes, were significant for serotypes 6A and 6B. However, post-booster dose, no significant differences were found overall for PCV7 serotypes combined or for individual serotypes. A study from Netherlands, presented on the right side of the slide, assessed the effects of a 2-dose and a 2+1 dose schedule of PCV7 on vaccine serotype pneumococcal carriage in children, and showed significantly lower prevalence of PCV7 type carriage at 18 months in the 2+1 group than compared to the 2+0 group. And no statistical difference was found when measured at 12 and 24 months. Again, I'm presenting this complex forest plot, which summarizes a systematic literature review of PCV carriage studies that are published between 1994 and 2011. Here, there were no direct comparisons between the schedules made, and vaccine type carriage was compared between those with vaccinated compared to those unvaccinated. And again, this slide is in your handouts, but rather than go through this forest plot, I will summarize the key points on the next slide. 10 clinical trials evaluated differences between vaccinated and controls for 2 or 3 dose primary series before booster. And there were a total of 23 arms examined, And all arms of a 2-dose primary series found reductions in vaccine type carriage prevalence among PCV recipients compared to controls. And all but one arm with 3-dose primary regimen observed reductions in vaccine type carriage, and most of these were statistically significant. 13 clinical trials assessed vaccine type carriage with samples taken after the first year of life. Among the 29 arms reported in these studies, 28 showed reduction in vaccine type compared with control subjects. And the differences, as I mentioned, these comparisons were made between vaccinated and unvaccinated, so the comparisons between the schedules have to be made across study, which is a little bit difficult to discern from this analysis when we are making the comparisons across studies. So in conclusion, for the colonization, for the carriage outcome, all schedules, 2+1, 3+0, and 3+1 show to reduce acquisition of colonization with vaccine serotypes compared to no vaccine. 3-dose primary series appears better than 2-dose primary series before the booster dose within 1 to 7 months of follow-up after the primary series. No differences are observed at 12 months of age before the booster, and also no differences were observed after the booster. So now, just to bring it all together, after going through many, many slides and many, many studies, we summarize the results and the findings of the whole evidence review in this table. So the first question is there clinical efficacy data available by different outcomes for 3-dose schedules? And clinical efficacy of 3-dose schedules has been evaluated for all outcomes except acute otitis media. There are studies, both observational and controlled trials, available comparing directly 3-dose schedule to a 4-dose schedule for pneumonia, otitis, immunogenicity, and carriage outcomes. There was one PCV-10 trial evaluating efficacy of both 2+1 and 3+1 against invasive disease. However, the study was not powered to make direct comparisons between the schedules. In terms of differences observed between the 3-dose and 4-dose schedules by outcome, studies with invasive disease outcome show that both 3-dose schedule and 4-dose schedules are effective, but comparisons we're making are across studies. For pneumonia outcome, the difference between 3 and 4-dose schedules may be observed early post-vaccine introduction. No differences are noted for acute otitis media. However, this is the outcome with the least amount of data available for review. And for immunogenicity and carriage studies, the differences between the schedules with 3 and 2-dose primary series are noted following the primary series, but following the booster doses, differences were no longer observed or only observed for some serotypes. So after going through all this evidence, it is important to interpret all these results that we are seeing in the context of the US PCV-13 program. We are seeing differences in antibody response between the schedules with 2-dose primary series and 3-dose primary series based on immunogenicity studies, which may lead to differences in carriage and potentially lead to differences in disease rates. However, most of this body of evidence that we presented here, these were studies that were conducted outside of the national immunization program, so underlying population has not experienced the herd effects. In addition, serotypes in question are very rare in the US and therefore less likely to cause disease. Rates of PCV-13 type IPD are extremely low among children of between the ages of 6 to 11 months, and this is a window during which immunogenicity studies do show the differences between the schedules with 2-dose primary series and 3-dose primary series. And direct and indirect effects of 3-dose PCV programs at the population level are very similar to the ones observed in the US. In the following slides, I'm going to present some of the evidence supporting each of these statements. Results of a systematic review of PCV dosing schedules published from 1994 to 2011 that evaluate indirect effects of PCV on IPD among older children and young adults are summarized on this slide. Programs with both 3-dose schedules, 2+1 and 3+0, demonstrated large reductions in the incidence among young adults age groups. Reductions in vaccine type IPD were observed as early as 1 year after the vaccine introduction, and in general, these reductions for all schedules were higher when studies were conducted 3 years or more after the vaccine introduction compared to the reductions that are seen within the 3 years of the vaccine introduction. And the key point from this slide is that the indirect effects of 3-dose programs are very similar to the ones that were observed in the US with a 4-dose program. In addition, there was an editorial published by Grijalva and colleagues, which analyzed, an analysis was done for this editorial to compare indirect effects of the PCV programs in the U.S. and in the U.S. and England and Wales, which use a 2+1 PCV schedule. And incidence rates were compared for both of the analyses done for both countries were compared 4 years after the vaccine introduction. So it was the same time period after the vaccine introduction where the rate differences were computed. And what is striking when we compare these two graphs, if you look at the green bars, which present the rate differences for PCV7 type disease post-vaccine introduction, so it's 4 years post-vaccine introduction compared to pre-vaccine, the bars are strikingly similar between the two countries that use very different schedules. In addition, the results of the nasopharyngeal carriage study, which evaluated early impact of PCV13 on carriage of PCV13 serotypes, are presented here. And the carriage was evaluated among children 6 to 59 months of age and compared during the 5 sequential 6-month periods during 2010 and 2012, so shortly after PCV13 introduction and 2 years, through 2 years after PCV13 was introduced. PCV13 serotypes declined from 29% to a little over 8%. And serotype 19A carriage declined from 26% to 4%, and both of these reductions that were observed over the course of 2 years were significant. It is important to point out that from PCV7 serotypes, only one serotype, serotype 19F, was isolated during any study period, and vaccine serotypes 1, 4, 5, 6B, 7F, 9V, 18C, and 23F were not isolated during any of the study periods. And I also have highlighted the 3 serotypes for which the differences were noted based on the immunogenicity studies, which are serotypes 6B, 18C, and 23F, and particularly these 3 serotypes have not been isolated in this carriage study during any of the study periods. The risk of invasive pneumococcal disease among children less than 2 years of age is also low, as I mentioned earlier. Overall rates are 14.6 per 100,000, and PCV13 type rates are around 2 cases per 100,000. And what we wanted to see with this analysis is, given the window of time during which the differences in antibody responses following the primary series were observed, we wanted to see what is the risk of disease among children 6 to 11 months of age. So the slide here presents the distribution of PCV13 type cases less than 2 years of age by month of age. So you can see that more than a third of PCV13 type cases in this age group occur before 2 months of age, meaning that before these children would have received even the first dose of the vaccine. And only one PCV13 type case was reported in 2012 and 2003 among children 6 to 11 months of age. So you might ask, what does this all mean in terms of the coverage of the vaccine and who gets vaccinated and which doses are given when? And this addresses the question that was raised earlier, but what we wanted to do is we reviewed the PCV13 coverage data from National Immunization Survey to understand what proportion of children currently receive a total of 3 doses and which 3-dose schedules are given. According to the 2012 National Immunization data, as Dr. Moore showed on a slide earlier, 92% of children surveyed received 3 or more PCV doses, and 82% received 4 or more doses. And this I have this information in a footnote. This means that around 10% of children who received 3 doses don't receive a 4th dose. So the table here presents age distribution for the timing of the 3rd dose among children receiving a total of 3 doses. So this is a mouthful, so I'll try to explain. For example, at the top row, the 22% of children who received a total of 3 doses received a 3rd dose at age 6 months, and therefore we can say that they were vaccinated on a 3+0 schedule. Similarly, on the last row, 43% of children who received a total of 3 doses received their 3rd dose at 13 months or later. So therefore, they were likely, we can call this schedule a 2+1. And so the schedules in between would be closer to either 3+0 or 2+1. So given that only a small percentage of children were vaccinated with a total of 3 doses, this data cannot provide input on what the preferred 3-dose schedule would be. But however, we are able to see that among kids, first of all, that small proportion of kids do get a total of 3 doses, and that these kids receive a 3rd dose anywhere between the 6 months of age to over 13 months of age. So the big variation in 3-dose schedules. So in addition, we reviewed information on vaccine failures and breakthrough infections reported to active bacterial core surveillance in order to evaluate whether any particular incomplete PCV schedules were associated with breakthrough infections. So we first started with 817 children less than 5 years of age with IPD reported to active bacterial core surveillance during April 2010 through July 2013. Of these, 715 had serotyping data available, 443 had vaccination history, and 238 of these had received at least 1 dose of PCV13. So of these IPD cases who received at least 1 dose of PCV, 41 cases were caused by serotypes that are in a PCV13 formulation and therefore were classified as breakthrough infections. And 5 of these received full 4-dose PCV13 schedule, and therefore we classified them as true vaccine failures. So the following table, we examine the vaccination status of these breakthrough cases by serotype and by PCV13 schedule. Only 4 serotypes were associated with breakthrough infections. The majority of breakthrough infections, 74% to be exact, were caused by type 19A, followed by serotype 3, which is 22% of breakthrough infections, and we only had 1 case of 7F. Only 1 PCV7 serotype, which is again type 19F, was associated with a breakthrough infection. The majority of breakthrough cases were vaccinated using schedules other than 3+1, 3+0, or 2+1. And this, among the cases that are in the other category, the majority of those received only 1 dose of PCV13. Just to conclude it all, what the work group thinks about the evidence review, 3-dose PCV schedules are effective against IPD, pneumonia, and otitis media. Immunogenicity and carriage studies show that 3+1 schedule may be better than 2+1 before booster. No differences are observed post-booster for most serotypes. There's strong direct and indirect herd effects observed in countries using 3-dose PCV schedules. And the differences between the schedules that we're observing through the review of evidence may not be meaningful because PCV7 serotypes rarely cause disease in children and adults. PCV13 serotype disease is rapidly declining, and we've seen that herd effects are very similar with a 3-dose schedule or a 4-dose schedule, so no changes should be expected at the population level. So now that I have offloaded all this information on you, I would like to take a breath and go back to the slide that I presented before and remind you that the main focus of this session was going to be review of evidence, and there was a lot of evidence to review for the work group. However, work group did raise questions and points about all these other considerations that are important when considering a policy change. And I will only briefly mention some of the points that were raised during the work group discussions. For example, for policy and statute-related issues, I think we're all aware that a 3-dose schedule is not approved by FDA, and therefore it would be an off-label recommendation. Also, the work group members were concerned that the potential recommendation should be worded in a way that it will allow for the coverage of the insurance and insurance reimbursement if the providers were to choose to give a 4th dose. There are, of course, economic considerations. Cost-effectiveness analysis will be presented after this. And I'd like to point out that this is a published study that will be presented. The analysis was done before the work group discussions have started. So only in this particular analysis presented, only one policy option was considered. So if the work group discussions continue, the work group has not really gone to the point where we would decide on different policy options. So this analysis was done before all these conversations started on the work group. Also, there are, of course, programmatic considerations, and these programmatic considerations will vary and will be specific to a specific policy option that we will consider, and a specific 3-dose schedule that we'll be discussing. So just to conclude again, what the work group thinks that we can tell the committee is that including a 3-dose PCV13 schedule for routine use among infants would not adversely impact the individual protection against invasive pneumococcal disease, pneumonia, otitis media, although this conclusion is based on much fewer studies, or herd effects. Acceptable schedule in a setting of a mature immunization program and strong herd effects may not need to be the same as that is chosen at the time of licensure. And a 3-dose PCV13 schedule for infants is likely appropriate to maintain already observed benefits from 13 years of PCV's use in the US. Of course, there's much more work to be done, and first of all, we would like to seek input from this committee and from partners, AAP, AFP, in order to help us identify gaps in the data and evidence and additional information that needs to be collected. The work group would like to further review the data by timing of dose administration in the primary series, comparing the schedules with or without the booster, identify groups that would require separate consideration. For example, children with immunocompromising conditions. I think the point was raised about the Native American populations. So all these groups that might require separate consideration. Great process will be required to evaluate appropriate 3-dose schedules and consider both effectiveness and safety data. And following these steps, more specific policy options could be presented at the future ACIP meeting. And I would like to end with the following questions, which were already in Dr. Bennett's slides. These are questions to the committee that we would like to hear the discussion on. Is the available evidence adequate to consider including a 3-dose PCV13 schedule? If not, what are the gaps in information? And there are different factors to consider: evidence and data, gaps in evidence and data, also provider and practice level issues, the programmatic level issues, parent considerations. And does the committee have any concerns about potentially including a 3-dose PCV13 schedule for routine use among infants? And if I can open up for questions.
Yeah, Dr. Harrison.
Yeah, can you comment on the antibody persistence for a 2+1 versus 3+0? I'm thinking back to the UK experience with meningococcal C vaccines. where 3+0 had very good antibody response and protection for 1 year, and then it basically fell off to virtually no protection?
Right, so antibody levels following both the 2-dose primary series and 3-dose primary series do come down following the after a follow-up. And however, with the 2+1 schedule, you do get a boosting effect from a booster dose. With the 3+0, I guess with the 3+0, there is no booster, but in a setting of the circulating serotypes, you might get a natural boosting, and that's what we don't understand. The schedules that were evaluated, the studies that were evaluated, as I mentioned, they were conducted in a setting of no herd effects. So for those, there were not differences observed, but in a setting where the strains are not circulating, we may not see the same.
Dr. Curran.
So first, I'd really like to congratulate you and Matt on incredibly clear presentations and synthesizing a huge amount of data. The question that I really had was about slide 37 and was about that third dose of PCV, and that 6-month-olds, only 22% of 6 to 7-month-olds had received that third dose. And I guess my question is, were you surprised by those data? And do you have insight into why that percentage is what it is, and does it mean anything for us as we consider 3-dose regimens and we consider what the options might be? You know, there are the practicalities of when we are able to get 3 doses in.
Mm-hmm. So I guess I think one thing I need to point out, which may not have been clear, is that this is not a 22% of children. This is 22% children that have received a total of 3 doses, and that's already at 10% of population, or 10% of those that were surveyed. So it will be a 22% of 10% that would have received the third dose at 6 months of age. And that would be the schedule recommended. So for these kids, they received the third dose at 6 months of age, and they didn't receive a booster, so they received 3+0.
Okay.
Dr. Campos-Elko.
Yeah, I think what she's saying is that of the children who got only 3 doses, 22% of them got their third dose age 6 to 7, or during that 6 to 7 month time period. Is that what you're saying?
So at the bottom, is that pointed?
So that those 414 children got 3 doses by that age and never got another dose. But that doesn't tell you what percentage of children had 3 doses by that age. Okay.
Correct. So this is a small fraction of the population.
Dr. Kemp?
I think it would be very helpful to see that for 4 doses. I'd really like to see what happens, because the other decision, of course, if you're going to go to a 3-dose is, 3+0 or 2+1. And I have even worse concerns about the fall off at 1. So I think these data would be very important to see for kids who got 4 doses when they got the 4th.
Mm-hmm. Dr. Jenkins?
How old are the kids when the survey was done?
So the survey is done among kids 19 to 35 months of age. And annually, that's the age group that is being surveyed.
Dr. Campos-Elko.
The reason we're looking at this, I'm trying to figure out, other than cost, I'm being hard pressed to figure out a reason why we're considering this, because the schedule is set, everybody's used to using it, we're having good effectiveness of the schedule as currently used. Why are we considering altering the schedule? Is it, and the only thing I can come up with is cost and potentially some adverse reactions with PCV 13 and influenza vaccine together. Those are the 2 reasons I've come up with. Is there any other reason why we're considering this? Now, having said that, and let that question rest for a minute, I do think it's worth looking at, but I can't comment on it right now because I don't know how good the studies were. You gave us a lot of studies, told us what kind of studies they were and what the results were, but I don't know how good they were. And I wouldn't be willing to change a working schedule without knowing the quality of the studies on which we're basing the evidence.
First of all, I'd like to say that the cost, even though we are presenting cost effectiveness analysis, cost was not one of the considerations and one of the points that the working group discussed, because we realized that the cost effectiveness analysis relies on the assumption that the price of the vaccine will not be adjusted. So that was not one of the considerations. It's a job of the work group to review the whole body of evidence as it accrues, and the evidence started emerging from multiple locations in the world showing that 3-dose schedules work, and it's simply a matter of doing our job to consider all the available evidence and see whether it warrants the change here as well.
Along that point, I just want to make a follow-up and maybe pick on Ms. Groom and Dr. Whitley-Williams on this. If there are populations for which you would have compelling evidence to continue with a 4-dose schedule and you move to a routine 3-dose, how good are we at identifying those high risk and following through with that? And I'm not necessarily looking for an answer right now, but I think that needs to go into the deliberation. I have Dr. Warshawski.
Hi, Bryna Warshawski from the National Advisory Committee in Canada. I just wanted to give a little perspective because we have been using the 2+1 schedule for our PCV 13. It's a permissive recommendation by the National Advisory Committee on Immunization, which means that we federally set the recommendations, but each province can then choose what they decide to do. So looking at what they've chosen, 11 out of the 13 provinces have decided to go to the 2+1 provinces and territories. They're at the 2+1. There's 2 small territories that have decided to stick with the 3+1, where there's a predominance of First Nations, Aboriginal communities, and they're quite small. So in implementing that, though, we did choose the 2, 4, and 12, and part of that was to try to make sure that the booster was given at the 12. We felt that would be better, given that we know there's been some failures with other conjugated vaccines when you give just the 3 doses without the booster, so we felt the booster was quite important and aimed to get that done at 12 months. But for us, that caused a problem in terms of crowding our schedule at 12 months, because as was mentioned before, we give conjugate meningococcal vaccine and MMR also at 12 months. So that was sort of an implementation difficulty, but we've overcome that with just encouraging people to give 3 doses all at one visit. We do make exceptions for high-risk groups, so anyone in the high-risk meningococcal groups, they do get the 3+1. Instead of 2+1, they're getting 3+1. And one of the analysis that people looked at is sort of the incremental cost of that 4th dose and how much disease you're presenting with that 4th dose and how much that costs, and that became some of the considerations as to why the 2+1 was very attractive, because as you heard from the data, it's quite effective, and the incremental cost of the 1 or 2 cases you might not prevent is, with that cost of that extra dose, is quite large.
Ms. Pellegrini.
I think on the question of why we're considering this, it's worth putting out there that if we could consult them, I think the 0 to 12-month-olds would vote wholeheartedly for a 3-dose schedule, regardless of whether it's 2+1 or 3+0, and that their parents probably would too, if we could, offload 1 needle stick during that period.
If I can just add one more, there was a part of the question that I didn't respond to, which was on a quality of evidence. And so quality of evidence is something that the work group will consider in detail when the grade process and the grade framework will be applied. So this is not apparent in today's presentation, but that is something that will be considered by the work group. And another thing is the safety, also associated with co-administration with Prevnar. That is something that was brought up by the work group and will be discussed as well.
Dr. Sun.
I'm not sure that this is the time for me to make the statement from FDA, or should I do this after the discussion of the cost effect?
Actually, we're just chatting on this, and this would be fine.
Okay. So I would like to give the FDA perspective, and we do have a prepared statement on this particular topic. The FDA appreciates the opportunity to provide input into this discussion of PCV 13 reduced dosing schedule. in healthy children. FDA and CDC staff have been working together on this issue since February of 2012, and FDA has considered the available evidence as well as the regulatory implications. And we understand that the ACIP is now evaluating the evidence supporting a possible recommendation for a reduced dose schedule for PCV13 in healthy children. We have concerns that could result from a discrepancy between the ACIP recommendation and FDA-approved vaccine labeling. With regards to a 2+1 or reduced dose schedule, we agree that the observational data, primarily with PCV7, provide some evidence that the reduced dose schedule is effective against invasive disease. Nevertheless, FDA notes the concerns, several concerns with the removal of one of these doses of PCV13 from the vaccine series. No studies for PCV13 have been compared the effectiveness of the 2+1 with the 3+1 schedule we have right now for prevention of invasive disease. The only published head-to-head randomized controlled trial comparing the 2+1 and 3+1 schedules reported higher antibody levels for most serotypes between the third and fourth dose of the current US 3+1 schedule. Also, with regards to otitis media, the other indication for which PCV13 is approved, no data are available that compare the effectiveness of the different dosing schedules of PCV13. And in the absence of specific safety or efficacy concerns regarding the licensed product, FDA does not have the authority to compel the manufacturer to conduct studies of PCV13 comparing a 2+1 schedule to the licensed schedule, or to submit safety and efficacy data in support of a label change. The licensed vaccine has been shown to be safe and effective with the 3+1 schedule. When evaluating a labeling change, FDA reviews the data submitted by the manufacturer. And if the manufacturer could not demonstrate adequately the effectiveness of the abbreviated dosing schedule, then FDA could not approve a labeling change. The FDA raises these issues because Prevnar 13 is a universally recommended childhood vaccine. FDA believes that a discrepancy or ambiguity between an ACIP recommendation and the labeling for the vaccine regarding the dose schedule could lead to confusion amongst parents, healthcare providers, insurers, and the manufacturer. So that ends my statement from the FDA perspective.
Dr. Lair.
I'd like to go back to a general comment. Let's say we have vaccine X, and 5 years later we find that only 2 doses of vaccine X are necessary instead of 4 doses. What evidence would the ACIP need to allow it to say we only need 2 doses? I really want to compliment the work group for bringing up this issue, because if the evidence is out there, maybe we should not be needing 4 doses. So I think they're creating a conversation of what does the ACIP need to say that 3 doses are just as good.
Yeah, thanks. I just wanted to second that. I just applaud this work group for taking this on, and I think these are issues we should always be looking at as new evidence comes along about existing recommendations and existing vaccines on the schedule. So I think you've just done a tremendous job, and at least we're starting a conversation.
And Ms. Hayes.
Dr. Moore, with the AIM. That's okay. I just wanted to say, from a immunization program standpoint, we do agree that this is a very important conversation to have. One of the concerns I see from my state when I look at our own data is the concern about if we were to go to something like a 2+1 schedule, we struggle to get those kids after their first birthday in for that booster dose. That's often the one they miss, and you see that. So if we were to drop one of the infant series, my concern is, have we created a nice safety net for children who miss that booster dose because they're generally getting that 3+0 if they're not getting a booster dose? And if we were to drop one of those infant doses, what about those who then miss out on a booster dose and then they're ending up with only 2 doses in a primary series for their incomplete protection? are we eroding that safety net that currently exists in the 4-dose total schedule? So that's just another issue to deal with, is the logistics of making sure the booster dose coverage is as high as it needs to be to maintain the level of protection we expect.
Dr. Sir.
Along a similar line of thinking, and also in line with Dr. Kemp's request to have this data that's up on the slide right now shown for children who received 4 doses of PCV, I think we should look at the younger doses at 2 and 4 months, or particularly the 4-month dose, and see how many children are delayed in getting that 4-month dose, because if we went to a 2+1 schedule, they would end up maybe getting a 1+1 schedule. And it's probably not a large number, but I think we should see the numbers.
Ms. Groom.
Thanks. I know you weren't actually looking for an answer, but to just give a little bit more on the Indian Health Service perspective, this is one of the reasons why we would like the working group to at least look at that. You know, certainly if the American Indian population was considered a special population in certain geographic regions for a 4-dose series, the Indian Health Service can implement that, but we are not the only providers that see American Indians and Alaska Natives, and so this definition of who is really at risk becomes much more complex when you have 2 different recommendations.
Dr. Dushan.
Just related to the previous comments about the programmatic implications and feasibility of compliance with a 2+1 or 3+, or particularly a 2+1 schedule, I think that's a real important consideration. And I'm on the work group, but I'm sorry I didn't bring this up on any of the calls, but are there any, is there any research available on the types of systems that the other studies are describing, you know, when you're looking at the alternate schedules and the success or failure of them in different environments in different countries, how their immunization infrastructure compares with ours with respect to completion of doses at various ages, and whether or not we could do any research, or there may be research available that I'm not aware of, on our likelihood of success at getting people immunized if we went to the 2+1 route.
Yeah, thank you for that point, and it's important, and I don't have that information, but that would be something that we would need to gather information.
Dr. Kimberlin.
The AAPCOID will be discussing this weekend, and so there'll be more formal and thoughtful feedback at that point. I would say that for me, slides 7 and 8 seem to be, of the presentation you just had, seem to be the most informative, looking at vaccine effectiveness of against invasive pneumococcal disease. And it appears to me that, generally speaking, the 3+1 schedule looks better than the 3+0 or 2+1 schedule. We've had great success, I think, as was mentioned earlier with the program. I personally would ask the question, why rock the boat now?
I mean, one note of caution is when comparing these schedules across the studies, that the populations are also different, and 3+0 schedules were used in, those were studies done in Africa, and the study with the 2+1 was done in Finland. So when we extrapolate this data, we have to be cautious.
Mr. Hausbeck.
Hi, this is Phil Hausbach from Santa Fe Pasture. I do represent a vaccine manufacturer. We do not make a pneumococcal conjugate vaccine, but I had a couple points, or at least some questions that should be considered here. First of all, I think there were a lot of good studies that were presented here. What I think is missing is a bit of evidence of the unexpected benefit of the immunization of this population in the United States in this schedule, and that's the herd effect relative to what's going on in the elderly population. So I know there was some data there, but it's pretty scanty compared to the other evidence that you were trying to present. The other thing that I guess comes to mind is what happened with Hib during a Hib shortage. We had to go to a 3+0 schedule temporarily. And when unimmunized populations got exposed to the underlying circulating organism, we had a couple of deaths and we had disease occur. I also am concerned about the way behavior is today in terms of acceptance of immunization or confidence in immunization. When you go to a 3+0, I talk about the Hib piece, but if you go to a 2+1, we do know that in the booster doses, you see a reduction in immunization rates. And will that just continue and expose, again, more vulnerable populations, whether it be herd effects for other populations or populations that are unimmunized, and those populations tend to be increasing these days.
So related to the comment on herd effects, there's a vast number of evidence from countries that are using 3-dose schedules that do demonstrate, and this is just a snapshot that was part of the systematic review that was done. So the table is actually excluding some of the older age groups because of the focus of the paper, and that was the reason. So this slide clearly shows herd effects in younger adult age groups, and they are very similar. If we also need to take into account the number of years post-vaccine introduction and compare it to the same time period in the U.S., but the similarities are striking. But also, the next slide, which includes the elderly and compares the herd effects across 2 different populations using different schedules, which also show that the herd effects in the elderly are also very similar compared to the programs that use the 3-dose schedule.
Dr. Jenkins.
I'd like to offer a perspective similar in a way to Cindy Pellegrini's, in that it seems to me this is an important conversation from a public trust point of view. I think the public is really concerned about the number of immunizations that we give children, and are they all really necessary? And I think to look really, really carefully at the science, clearly, of this and the longer term effect, especially what you talked about in terms of the decreasing prevalence of some of these diseases now, we need to make these kinds of assessments to see, does the schedule need to change down? I think we're always aggressive about changing the schedule up, but I think we also need to consider when we need to ratchet the schedule down.
Comment at the microphone.
Yes, thank you. Thank you very much, and good afternoon. My name is Luis Yoder, and I'm representing Pfizer Medical and Scientific Affairs. The first thing is I would like to thank you very much for contributing to this discussion, which is a very important debate. I think we at Pfizer believe that in the context, and I think it's important to emphasize that we are talking in the context of the United States, the clinically proven 4-dose approved FDA 4-dose schedule is the optimal schedule for the prevention of pneumococcal disease. I think we've shown since the year 2000, when PCV7 has been introduced, extraordinary results in terms of reductions of disease in invasive, non-invasive disease, in vaccinated and non-vaccinated individuals. Dr. Moore has shown us beautiful, encouraging results with a 3+1 schedule after 3 years of introduction of PCV13. I also applaud very much the job that Tamara and the working group has done about trying to collect the evidence available, but we believe that the current evidence available does not support at this stage the reduction to a 3-dose schedule because of 3 considerations that I think have been mentioned here, and perhaps in further discussions are going to be elaborated. The first one is the quality of evidence. I think we've seen a lot of studies, but what is clear is that there are no randomized studies, neither with PCV7 nor with PCV13, that compares a 3+1 or versus a 2+1 or a 3-dose and a 4-dose schedule, especially for non-bacteremic pneumonia and also for acute otitis media. It is also very difficult, and although I understand that this slide and in terms of indirect effects, it is, there is no comparison also in terms of impact of indirect effects between a 3-dose and a 4-dose schedule simultaneously. So in terms of the magnitude and the speed of a 4-dose schedule versus a 3-dose schedule, I don't think that we have enough evidence to demonstrate that they're equivalent. Especially in countries, and I think you've mentioned that we have to be very cautious when comparing country versus country, and especially in countries with disparities in compliance rates. And I think that has been a discussion that has been raised, and that's my second argument about compliance rates. It's been argued that if you increase compliance rates, you might mitigate the potential negative effects that a reduction to a 3-dose schedule may have. But I think it's true also, and we've been seeing that around 20% of the kids do not receive the 4-dose schedule. We simply do not know, and I'm not going one way or another, we simply do not know what might be the impact in those kids. And those disparities are further emphasized if we look at ethnicity, if we look at socioeconomic conditions, or if we look at whether the provider is public or private. So I think it's important to understand that we just do not know whether you can sustain dose effect if you go to a 3rd-dose schedule. And my last argument here is just to concur with the FDA statement. We have to remember that PCV 13 was licensed in a 4-dose schedule at 2, 4, 6, and 12, 15 months. And that was based on the evaluation of the 4-dose series immunological responses. Now, it is highly unlikely under the currently licensing criteria, a 3-dose schedule will be licensed. And with that, I would like just to conclude that while we still consider that the 4-dose schedule, in view of the spectacular results that we've seen, is the optimal schedule in the context of the United States, we really applaud, and we are very, very committed to continue the scientific dialogue and to contribute in any way that we can to generate the evidence to establish the best immunization programs, not only here, but in the rest of the world. Thank you.
Dr. Gorman.
I have a question that started on slide 2, which was dealt with the, and that it's a really simple slide because I have a really simple question. So when the EMEA approved the 3-dose schedule, was the packet that was submitted by the sponsor supportive of that particular recommendation? Does anyone know?
Yeah, I can answer that question. Yeah, I think we have to qualify that statement. For individual protection, the approved schedule in the European Medicine Agency is a 3+1 schedule. However, in the context of a national immunization program, an alternative schedule, a 2+1, can be considered by countries. So I think it's yes, but I think for individual protection, a 3+1 schedule is the recommendation.
Thank you. Could you then answer the same question for the 34 countries that have introduced the PC13 or PC10 on a 3-dose schedule?
I'm sorry.
Is it the same response that it was, the packet was a 3+1, but then there was an acceptable alternative of the 3-dose schedule?
Yes. I'm sorry. Could you repeat the question, please?
I will try. Basically, there's a large list of other countries, not a list of countries, but a number of countries, where all of those countries presented a packet with a 3+1 schedule, and then they found a 3-dose schedule acceptable, or were some of them presented a packet of a 3-dose schedule?
No, the packet was always, in every country, a 3+1 schedule for individual protection. Many other countries have decided that a 2+1 schedule based on the immunogenicity data and in the context of national immunization programs is acceptable.
Thank you.
Cindy.
Luis, maybe you could clarify the packet that was submitted included data showing a 2+1 immunogenicity, is that right?
Yes, that's correct.
I think maybe we will, Dr. Warshawski, and then I think we should move on to the next section and then pick up any additional comments after that.
I'm Brenna Wachowski from NACI. I'm just wondering, thinking about the conversation this morning and the conversation this afternoon, which both relate to meningitis, serious infections, I wonder if, interesting to look at the cost per case averted for a meningococcal strategy versus the cost per case averted for the 4th dose in the pneumococcal strategy. I wonder how that would fall out.
Which may be a good segue into the next discussion by Dr. Stoecker on cost effectiveness of a reduced dose schedule.
Hi, I'm Charles Stoecker, and I'm presenting the economic analysis here. So this is the result of work published earlier this year, and the goal of this work was to evaluate the effectiveness of switching the PCV schedule from a 3+1 schedule to a 2+1 schedule. Here we're modeling the removal of the dose at 6 months, and we're comparing potential program cost savings with potential increases in disease, medical costs, and non-medical costs. Our model is a cohort model following a cohort the size of the 2010 US birth cohort. Events are tracked annually, except in the first year of life when we track events separately for those between 0 and 6 months old and those 6 to 12 months old. Events occur within the first 10 years of life, and then we track the consequences of those events through life expectancy. Our model is conducted from the societal perspective. We have costs in 2011 dollars. Our discount rate is 3%, and we're looking at a new steady state. So this is what the long-term effects of switching to a 2+1 schedule. So here are the health outcomes we consider. So our model is a decision model which has 2 arms. This is one of the arms, considering one of the dosages. And in this, we're looking at invasive pneumococcal disease and non-invasive disease. In invasive disease, we're looking at meningitis, pneumonia, bacteremia without focus, and all the other syndromes. For meningitis, all meningitis cases result in hospitalization, which can subsequently lead to fatality, mental retardation, deafness, or potentially no sequelae. For pneumonia and the other 3 IPD outcomes we look at in our model, the cases can result in hospitalization and fatality, or no hospitalization and then a fatality. For the non-invasive branches, we consider otitis media, which can lead to a tympanostomy tube placement or a case of acute otitis media, and pneumonia, which is non-invasive, which all-cause pneumonia, which can result in hospitalization and fatality or potentially no hospitalization. There are 6 key assumptions in our model. First, we assume that both schedules have similar direct effects against invasive disease. Second, we assume that both schedules have identical herd effects. Both schedules have identical replacement disease effects. And fourth, 2+1 provides zero direct protection against otitis media and all-cause pneumonia between 6 and 11 months. And 2+1 provides the same direct protection against OM and all-cause pneumonia as 3+1 after the booster dose. And then, importantly, we assume no price response from the vaccine manufacturer. Here are the baseline disease rates that we use in our model for those in their first 5 years of life. You can see that the first line are those between 0 and just under 1/2 years of age. And then the second line is those 1/2 years of age to just under 1 year of age. And our model goes down to age 10, but we only present the first 5 here for brevity. Here are the assumed percent reductions in pneumococcal disease by syndrome, age, and schedule. So these represent the composite of both direct and indirect effects. The differences between the 2 schedules are highlighted in red. The second to last column has the total of reductions for 2+1, and the last column has the total reductions for 3+1. So the 6.7 you see highlighted there for those between 1/2 and 1 year old is the indirect effect, since we assume no direct effect of the 2+1 schedule against otitis media. And then the 14.6 that we assume for the 3+1 the 3+1 schedule is after we add in the direct effect. Here are the vaccine costs and related parameters that we assume. The vaccine public and private prices are right there, about $100 and $120. The federal government buys about 65% of vaccine, and so those costs are weighted by that. Wastage we assume to be about 5%, which is in line what VFC contractees report. And then vaccine administration is weighted from with both public and private administration costs at about $15 a dose there. Here are our assumptions related to disease costs. The second column has the medical costs, and the second column the last column has non-medical costs. Non-medical costs include things like lost wages from parents having to take days off of work to stay in the hospital or take their kids to the doctor. At the top we have costs for inpatient pneumonia, and then at the bottom we have the long-term costs for outcomes like deafness and disability there. So this slide presents the quality-adjusted life years lost per episode of disease. So we use QALYs so that we can compare mortality outcomes with non-fatal outcomes like otitis media. And these are the weights that we put on each of these outcomes. These are from previously published studies that survey parents and ask them questions like how much they would be willing to give up of their own life to prevent an episode of acute otitis media in their child. So that 0.005 number there, to put that into context, that's about 1.8 days of life. So here's the first of our results slides. So this represents a very simple model where we assume that 2+1 and 3+1 have identical effects on all syndromes. So you can see that there are no additional cases of IPD, hospitalized pneumonia, any of our outcomes. And we look at the total cost savings, which is in millions of dollars here. So that's $500 million. And then I'm going to move on to our base case, where we assume there are some differences between the two schedules. So we, under our assumptions, in our model, there are an additional 44 cases of IPD, and this represents an 8% increase over about 550 cases of IPD in this age group of 0 to 10-year-olds. And then you can see there's an extra 1,453 cases of hospitalized pneumonia and 261,000 extra cases of otitis media. Total cost savings are lower than in the previous results slide because we've now incorporated potential increases in medical and non-medical costs due to these additional cases of pneumococcal syndromes. The key number for the cost effectiveness analysis are the ratios at the bottom. So the second to bottom row shows that we save about $300,000 per quality adjusted life year lost. And then the last line says that we save about $6 million per life year lost. And the difference between these two lines show that it's non-fatal cases that are really driving the cost effectiveness results in this model. Here is a diagram showing what are the most important influential inputs in our model. They're going from the most important at the top to the least important at the bottom, and there are hundreds of inputs in our model, and this slide could go on for a few more feet. So the top line there is the effectiveness of the 2+1 schedule against acute otitis media in the 1/2 to 1 year old age group. And the base case is shown there in the black line, so that's the $300,000 saved per quality adjusted life year lost. And it can range potentially from a little bit to the left of that, so a little bit fewer dollars saved per quality adjusted life year lost, all the way over to cost saving, which is undefined for this graph, but if you could kind of think of this as a bar going all the way to the right. The second most important parameter in our model is the quality adjusted life years lost we assign to acute otitis media. And under the ranges that we assumed in our model, that could range anywhere from about $150,000 lost per quality adjusted life year lost, or saved, all the way from $150,000 saved per quality adjusted life year lost to over $3 million saved per quality adjusted life year lost. And the other top 6 important inputs into our model are all on non-invasive disease and are much less important than those assumptions around otitis media. So this motivates us about which parameters to look at for our sensitivity analysis. So we turn first to look at other assumptions around the otitis media parameters. So the second column here shows our base case, again with the 44 increased cases of IPD and the $300,000 per quality adjusted life year lost in the second to bottom line. The second column shows that what happens when we assume that an otitis media quality loss is worth 0.011 years, or this is about 4 days instead of the 1.8 days we assume in our base case. And you can see that the cases in the model remain unchanged. It's still 261,000 cases of otitis media. But the second to the last line, which is the cost effectiveness ratio, changes from $300,000 to $143,000 saved per quality adjusted life year lost. So if we put increased weight on the otitis media parameter, we save fewer dollars per quality loss because we lose more qualities. And then the last column assumes something where it's like as if we put a 0 quality weight on otitis media, or specifically what we did here is we assumed that the two schedules were identical in effectiveness against otitis media. So here you can see that there are no longer 260,000 additional cases of otitis media when switching from 3+1 to 2+1. Instead, there are 0 additional cases. And here we come out with a savings per quality losses of about $4 million. We also looked at the sensitivity of our model to assumptions against other syndromes, and they were in terms of cost effectiveness, much less important. So the first column here, the first column of results here assumes that they have identical effects against IPD. So you can see in the first row, instead of the 44 additional cases of IPD, we see 0 cases of IPD. And the savings for quality loss increased to $305,000. So this shows that it's not IPD that's driving the results in our model. The second line looks at how important the assumptions surrounding inpatient pneumonia are to our model. And here you can see the second line, instead of 1,453 additional cases when switching the schedules, we see 0 additional cases. And skipping down to the second to bottom line, we see $323,000 saved per quality adjusted life year lost. So again, not much different from our base case of $300,000. In the last column, we assume that the two schedules have identical impacts against outpatient pneumonia. And we've zeroed out here the third line instead of the additional 10,000 cases of non-hospitalized pneumonia when switching the schedules. We assume 0, and we see very little change in the $300,000 per quality saved. Here we go through an experiment where we try to imagine what would happen if we could increase coverage. So in our model we have coverage for the primary series and coverage for the booster dose. And so these are denoting coverage for the complete schedule. So currently or at least in our model, we used a coverage rate of 83.3%. That's for the 3+1. And if those same people then only get the 2+1, we get the base case, which is shown there in the first column. If instead we can increase coverage for a 2+1 schedule to 86%, we get a result that is cost saving in life years lost. So we've done two things here. We've decreased the number of doses assigned, and we've increased the coverage. And if we could increase the coverage by about 3 percentage points, we would actually be preventing more deaths than we currently lose. And then in the last column here, if we could increase coverage for the full schedule by about 10 percentage points, we would completely negate any potential losses of quality adjusted life years. So the second to last line in the last column says that the results are cost saving. So this says that we save money and we increase health outcomes when we're looking at quality adjusted life years. So there are several important limitations for this study to note. First, the 2+1 and 3+1 comparative effectiveness is based on observational studies. There is some RCT evidence that effectiveness is similar for invasive disease. There's no RCT evidence of PCV13 efficacy. Estimates here are adjusted from PCV7 to match the serotype distribution of PCV13 serotypes. Third, evidence of herd immunity is based on international comparisons and immunogenicity. Fourth, data quality on the effectiveness of 2+1 against non-invasive disease is especially limited, as has been previously mentioned. There is great uncertainty about how important the otitis media outcome is, and that turns out to be a key input for the cost effectiveness model. So depending on what weight you want to assign to each ear infection, it determines how cost effective you think this policy change would be. And last, this doesn't model continuing 3+1 for high-risk groups. So here we've attempted to put this schedule change in the context of other schedule changes. So here we do a little bit of mental gymnastics where we imagine a world where we were we had a 2+1 schedule and we were considering moving to a 3+1 schedule. So here we're looking at costs per quality saved. So in our base case is down here at $300,000. This is adding that third dose in the primary series would cost us $300,000 per quality adjusted life year saved. And this is more expensive than other routinely recommended preventive interventions, including Lyme disease and areas with particularly high attack rates, which was estimated to be about $200,000 per quality adjusted life year saved. If we put a larger weight on the otitis media parameter and assume that preventing an ear infection is worth giving up about 4 days of life, then the cost per quality drops to $140,000. On the other hand, if we assume that we don't put much weight on the otitis media parameter, or we assume that the schedules are identical against otitis media, we get a cost per quality of just under $4 million. So in conclusion, compared to a 2+1 schedule, the current 3+1 schedule is less cost effective than other routinely recommended preventive services. The cost effectiveness of the third dose in the 3+1 schedule could fall into the range of the other routinely recommended services if the quality loss associated with otitis media were 4 days instead of 1.8 days. And last, if the effectiveness of 2+1 and 3+1 against otitis media are equivalent, then the cost effectiveness of the 3+1 schedule falls far outside the range of other services considered to be cost effective. So I'd like to thank my contributors and open it for questions.
Yes, Dr. Curran.
So can I ask a question about the assumptions around acute otitis media and the pneumococcal burden associated with it? I'm assuming that this is really a moving target, and that as we have PCV 13 and as herd immunity continues to increase, that the proportion of otitis media that is pneumococcal associated is going to continue to decrease. And I note that, for example, in I think it's slide 9, some of the assumptions about the burden of pneumococcal associated disease are from, say, 2003, and we may just be emerging into a very different era in terms of our pneumococcal otitis media burden.
So for otitis media, what we did is we assumed we used disease inputs from prior to PCV7 and then applied the PCV7 effectivenesses to those disease rates. So I think we've done a pretty good job of matching the impact of the vaccine with the disease rates that were prevalent when that impact was measured. So I guess the concern, the reason we did it like that is because we start with a large otitis media burden before PCV7 comes along, and then we hit it with a vaccine that's pretty effective in 3+1. But then we're worried that if we scale it back to a 2+1 effectiveness, which is about half as effective for this particular age group, it's not that we would increase by a small amount relative to what we are here. Potentially, it would increase by a much larger amount, since we're basing it on that large baseline disease incidence rate from before 3+1 knocked it down. So these are very conservative assumptions about when we start the disease and what vaccine effectiveness to apply to those. So we're starting with the largest possible disease burden that we could, so that we can get the maximum possible difference between the two schedules. So as a conservative assumption.
Dr. Kimberlin.
Apologies for my slow uptake on some of this. On slide 7, on the 6 key assumptions, you say that the first one is that both schedules have similar direct effects against IPD. And then on slide 15, with base case of 83%, I think, coverage, you have 44 increased cases of IPD. If it's assumed to be similar, how could there be increased cases?
So similar, so this is the last line of slide 9 here. So for 0 to 1 year olds, we assume there's a 96% effectiveness in vaccine in both schedules here, and then the difference is this 98 number here. So for everyone older than age 1, we assume that the 2+1 schedule only prevents 98% of vaccine type IPD, and the 3+1 prevents 100%. So that's the difference, and that's why it's similar and not identical.
Dr. Moore?
Thanks, Kelly Moore, AIM. 2 other clarifying questions. One had to do with any consideration of antimicrobial resistance and those concerns with respect to treating acute otitis media rather than preventing it with vaccine. Because although it's not a quality-adjusted life year issue, certainly antimicrobial use and resistance patterns that are changing and making it more difficult to treat potentially are thoughts, concerns there. The other question actually is a clarification on the sensitivity analysis and the base case coverage versus the expanded coverages. Are the expanded coverage numbers looking at the expansion of a 2+1 relative to the base case of what we currently get with our 3+1, or is it looking at expanded 2+1 relative to that same percentage with the 3+1, if that makes sense? So when you're looking at the benefit of expanded coverage, are you looking at that benefit over where we are currently with our 3+1 at 83%, or are you looking at 93% 3+1 compared to 93% 2+1? Does that make sense?
It does, and the answer is a little bit tricky. So in our model, we assumed that there's 2 different coverage rates, one for the primary series and one for the booster dose. And so this is kind of a composite of those 2 options that you laid out, where I think in our model, the primary series has a coverage rate of a bit over 90%, 93% maybe even. And so this is when those guys with a primary coverage of 3 go down to 2, and then we add a booster dose for them. So this is increasing the guys that adhere to the schedule up to 86%.
Okay, I don't feel as dumb anymore. Thanks.
And I'm going to punt the first question to the disease experts about the antimicrobial resistance.
Dr. Bennett?
Thank you. Thanks for this presentation. I do have a question, even though I've heard the presentation before, so I apologize. But I was interested in the assessment of quality loss, and I know it's based on surveys, is that correct? But I wondered if in the last slide or near the end, I think you varied the assumption for otitis media and how much quality loss it causes in order to show that it would fall in a more reasonable range. Did you do that for any others? Because I'm just struck by the way the quality losses cluster, essentially, and they're not as great as I would have expected them to be for some of our outcomes.
So what we did for the ranges on the quality inputs is we looked at the surveys that we get these from, and we used the ranges from those. So like if there was a 95% confidence interval around the resulting quality loss, we used that. Otitis media is a special case because there was an alternative study done looking at how much parents would give up to avoid a case of OM in their kid. And this study came out with this 0.11 number, and so we wanted to use this number to see what it would do with our results. Now, we weren't totally confident about using that particular study as our base case, since we were worried that parents may have been answering that question not as an acute case, but as an ongoing condition. There were answers that ranged, parents would give up about 8 months of their life to avoid an ear infection in their kid, and we were worried that there may have been some issues in the survey there, but we wanted to see what that would look like in the results.
Yes, Dr. Brady.
I have 2 questions. One is, you mentioned one of the limitations, which it doesn't take into account the impact of high-risk groups. And for the pneumococcus, we have some very high-risk groups. But then we also have another kind of moderate risk group, which is based on race and ethnicity, and that actually represents a relatively large proportion of the population. And is there any way to potentially model that? Because I do think that we don't want to give up what we found, which was mentioned, was that by using the vaccine, we have significantly altered the disparity in pneumococcal disease for the strains that are in the vaccines. And I would hate to lose that. And I would like to know if that would significantly impact the cost effectiveness. The other thing is, I do have a problem with these qualities. A parent who says that otitis media is more severe than or is just about the same severity as an inpatient pneumonia, that's not right. I mean, I can guarantee you that there's a difference. And while a lot of parents who have a child who has many episodes of otitis media will, always be upset about that, having to put a patient into the hospital is more than 0.001 more severe than than otitis media. So I really think there's a lot of problems with these qualities.
I agree with you. I think the quality results here are showing that inpatient pneumonia is about 20% more severe than an ear infection, and there's
20% more severe.
Well, that's 0.006 over 0.005.
Or even so, you're talking about also meningitis. Now, I'm assuming that you're pulling out the deafness and disability loader, but having a patient in the hospital for 10 days, potentially longer, compared to otitis media, it seems like it'd be more than just 4 times.
I hear your concerns there, and as for your first question, absolutely, that's completely possible to model high-risk groups separately.
Dr. Foster. Dr. Foster.
This was Steve Foster from American Pharmacists Association. This is actually a comment based upon my length of being here. But I do recall that when we were talking about the meningococcal vaccine, the quality costs were quite significant, but we decided to keep that on board just because of practice issues with that too. And you did not, am I remembering this wrong? I guess mostly this because we haven't in the past had discussions about removing things from the schedule, and if we do that, there probably is going to be open up a big old ball game here as we look at that. But
So on this slide, I do have one of the results from the MCV4 discussions, and that's the third line here, and that was about $160,000 per quality.
Dr. Decker, you've been patient, so please.
Thank you, sir. I actually want to follow up on an issue that was alluded to by Dr. Sun. And to frame that, sometimes this committee considers making an off-label recommendation that increases protection. Sometimes, like today, it considers making an off-label recommendation that possibly decreases protection. And in either case, there's either a good likelihood that the companies will get the labels aligned with the recommendation in a reasonable time frame, or there's very little hope of that ever happening. And I think the committee needs to be sensitive to how those different situations play out because they're very different. And I'll give you two easy examples. This committee has recommended that the number of doses of rabies vaccine given in the event of acute exposure be decreased from 5 to 4. There is no chance on earth that the label will ever align with that recommendation because it's impossible to provide to the FDA the type of evidence necessary for label change. So it is a permanent situation now that when we are contacted, as we are regularly, by physicians or others who are inquiring about rabies protection and who cite the ACIP recommendation, we tell them it's simply wrong and that you require 5 doses in the United States. That's the label, that's the law, and we're forbidden to say anything else. Now and that's what would happen, I believe, if you reduce the number of doses of pneumococcal vaccine. A counterexample is a situation like meningococcal vaccine where you decide to recommend a booster at 5 years. In that case, you're increasing protection. It puts us in a somewhat different stance, but more importantly, we already had underway, or we immediately began, the studies necessary to put that in the label. It was clear how to do that. We filed them with the FDA, and the FDA has generally been very permissive about our explaining that, yes, the ACIP has a recommendation that's gotten ahead of the label, but we're headed that way, and so on and so forth. We've got, not only do we answer all the phone calls at 1-800-VACCINE for our products and a similar number for the other guys' products, but we've got hundreds of people in doctors' offices every day who are forbidden by law from telling them your recommendation if it differs from the package insert. So you've got to keep that in mind.
Thank you. Dr. Pickering has a ongoing study here.
Yeah, Mike, it's good you bring this up because we get a lot of calls from physicians also about off-label use of various vaccines. So either before or about the time that the 2+1 schedule was being discussed, being considered, we developed a collaboration with investigators at Emory University School of Medicine and with Dr. Sun, specifically to initiate a project based on 2 hypotheses. And the 2 hypotheses were, number one, there are numerous discrepancies between FDA licensure requirements and ACIP recommendations for many vaccines. We went back to 2000. We picked 2000 as an arbitrary date for use of the vaccines in children and adults in the civilian population. The second hypothesis was that healthcare providers are aware of and concerned about discrepancies between ACIP recommendations and FDA licensure indications. So these 2 hypotheses led to 3 specific aims of this study. Number one is to summarize the FDA licensure requirements and the ACIP recommendations for all vaccines licensed since the year 2000 for use in the civilian population in the United States, all ages. Secondly was to enumerate discrepancies between the vaccine products licensed by the FDA for use under the U.S. FDA Biologic License Application Program and the ACIP recommendations for the same vaccines. And then lastly was to assess the knowledge, attitudes, and practices of pediatricians, family physicians, and OBGYN physicians regarding discrepancies in FDA licensing and ACIP recommendations, and determine whether the FDA licensure or the ACIP recommendations are being followed. And this is being done with a survey that is being sent out by AAFP, ACOG, and AAP. And as you said, the preliminary review of these data indicates the 3 categories. One, there's agreement. Second is that the ACIP recommendations extend beyond the licensure. And then the third one is that the ACIP recommendations do not meet the full licensure of the FDA. So these preliminary findings are not surprising because the FDA and the ACIP follow different mandates with regard to vaccines, as you know. Not everybody knows as much as you know about these differences and why they occur. So these data are being analyzed, and we'll have more about this project in the near future.
Dr. Dushin?
Thank you. I need to be educated on this. Tell me again how it's illegal for, or is it illegal for vaccine manufacturers and their representatives to provide ACIP guidance when it's in conflict with the FDA package label? It's illegal to provide the ACIP guidance? Is that correct?
Wellington may want to answer this, but their marketers must stick with their labels, but clinician organizations and the ACIP and all of the rest of us who educate providers and the public follow ACIP or AAP or ACOG or other standards of care. So the drug detailing reps are not allowed to market outside of what is on the label. They can't, when the pneumococcal vaccine was initially licensed, it was licensed for invasive bacterial disease and otitis, and it did not get an indication for pneumonia because the initial studies did not meet the FDA's requirements for demonstrating protection against pneumonia. So the company was not allowed to market the vaccine as something that was effective against pneumonia because of that. So they have, their drug detail reps must follow what's on the label. Whether that is the primary source of health promotion education for clinicians, I don't know, but the rest of the bodies are considered standards of care for practices, and we educate based on, the annual schedule that you guys vote on.
So there's a federal law that prohibits the pharmaceutical representatives from providing ACIP guidance when it's in conflict with the label, the FDA label. Is it illegal for the FDA to provide ACIP guidance in that instance also? For example, if someone went to the FDA and said, I would like guidance on how to use the rabies vaccine, is it illegal for you to provide the ACIP recommendations to the public?
I'm not a lawyer, so I'll try to answer this question best I can. First, to clarify that the FDA does not regulate medical practice. Well, we regulate products that we approve that's been demonstrated to be safe and effective. However, so what a physician does as part of medical practice with FDA licensed products, that's considered practice, and we don't regulate that. However, a company cannot go advertise or promote any use that's outside of what is in the label, because you can imagine a situation where if they demonstrate with safety and effectiveness with the N1 disease and then use that to promote a whole series of other that have not been proven to be safe and effective, that would be untenable for patient safety. So I think we need to draw a difference between medical practice by the practitioner versus what a commercial company can do.
So if someone went to the FDA and said, how should I use the rabies vaccine, you would not be able to provide them with the ACIP guidance?
I mean, we actually have in our some labels ACIP recommendations. However, we cannot, if there's a difference between the label and ACIP recommendation, we have to go with the label because that's based on the evidence that we reviewed.
And just one brief additional comment. The one exception to our gagging on anything that's outside the label is that an individualized conversation between medical professionals, such as you and me meeting in your office, I can talk about anything as long as I make it clear what's off label. But the sales reps, nobody who's involved in sales has that flexibility.
I'm just going to step in terms of some time issues and go back to the work group and just ask, are we getting sufficient discussion and questions so as to inform the working group in terms of directions that you should be going? I think to summarize, there's a great deal of
differences of opinion around the table and around the room, which I think is very appropriate for this. We've heard that there are reasons to seriously consider a reduction in doses in terms of some parental issues, in terms of potential cost issues, in terms of things like that. There are also significant concerns in terms of immunization programs. The interruption of a successful program right now, and especially as it concerns higher risk individuals who might get swept under the carpet by a change. So I think at the end of the day we ask, do we have sufficient information, not to solve the problem, because we're not going to do that here today, but to inform you in the next steps going along. And I'm also looking over to our subject matter experts. I know that Dr. Baker had a final comment here as well.
Just a comment, we have 2 recommended vaccines for pregnant women. They have no labels.
And Carol, that's a real problem, because when ACIP made that recommendation for pregnant women for flu and for Tdap, the people, the manufacturers, the drug reps, as Mike said, went into the offices, were asked whether or not they can give vaccine to pregnant women, and were told no. That's a bit of a deterrent.
Well, that's how Jeff began the conversation. For the people who market to physicians and educate, number one, don't feel too bad, because they're not even walking into OB-GYN offices if they're selling vaccines. I mean, seriously, it's a kind of a waste of their time. They can't really talk about them. But what I wanted to comment is that there are populations and there are vaccines for which, even though, and at the time these recommendations have been were made, there was no pathway in the FDA for licensure in pregnant women, because they've been protected from vaccine trials and other medication trials. I think that's going to change in the future, but sometimes you have to, from a policy disease burden point of view, make recommendations that don't match a label of an available vaccine. I don't think that we should do it very often as a group. There's been great progress in harmonization between the recommending bodies, the pediatricians, the family practitioners, et cetera. Most of the time everybody agrees, and I think that's great. Pediatricians, I can tell you, and I don't mean to be irreverent, but they wait for the AAP. I think family practitioners probably wait for the AAFP before they implement things. So with this partnership, policy should be in a situation favorable to implementation.
I think I'm going to do one more thing, just take the prerogative, because we have 3 public comments, and instead of putting them at the end of the meeting, since these are dealing with pneumococcal vaccine, I'm going to ask, is it Josh Raby? I think she's. And again, we ask you to state your organization and any conflicts of interest.
Yes, sir. My name is Joshua Raby. This is my wife, Bianca Raby. We are with Meningitis Angels, and we have no conflict of interest. On October 24th, 2010, I lay down with my son, Zachary. He's approximately 2 years old, a little shy. But we're laying down there watching football when lay down for a while, and he woke up and started running quite a little fever. Gave him some Tylenol, called the pediatrician, said give him a little bit of Tylenol, see how he does. He perked up. Next day made an appointment. Our child went there and they diagnosed him with the flu. We went from there, said, gave him some medication, went home, said if he's not better within the night to come back in the morning. The night progressed, it got worse and worse and worse, and we took him back to the doctor. They immediately admitted him. They admitted him, giving him fluids, saying that he was dehydrated, so he would perk up within, probably a couple hours or so. They administered the fluids. By the time we got him back to the doctor, or back into the room, They started administering fluids. He was completely lethargic. He didn't move. He wouldn't. You couldn't get him to react to a voice. You couldn't get him to do anything. The nurses started noticing actual rashes started forming, little black blotches forming on his legs, and we got the doctor to take a look at it. Immediately they called in a flight team from Cook Children's Hospital, which was approximately 3 hours away. So we need to get this little boy there. So they took off. Said only one parent could ride, so I went ahead and took off. Took off there. Got about 30 minutes down the road, my wife gave me a call and said you need to get back right now. And sorry. For the 30-minute drive, I was just praying, dear God, no. My wife's never held details from me. I went to the hospital room as soon as I got there. As soon as I got in there, my wife's in a separate room right beside of us. And they get in the room. I went in there in the room. My wife is just sobbing and has nurses around her. And by the time I got settled in there, the nurse came in there and said they had been performing chest compressions on my son for approximately 10 minutes. And they asked if they wanted them to stop. And all I remember is saying, please, just a couple more minutes. Just a couple more minutes. And they tried. They tried their best and they couldn't get him to come back. We went in there to say goodbye to my son, and I'll never forget seeing him laying there. He was just cold and black. Just absolutely lifeless. Looking back, we were in the transition of a move to Abilene, Texas, and in that move, we were getting a new pediatrician for my son. And once we got there, as soon as we got down there, the doctor said that basically he was due for his final dose or his 4th dose of Prevnar, and said he was also due for the flu shot. Said they would push out and go ahead and do the flu shot, and then at the next appointment, and then the following they would go ahead and finish with Prevnar, and but he didn't make it to that appointment. So in our opinion, that 4th dose is very important. Because I have no doubt in my mind that my son would be right here with me. And I would be here talking to you guys about this. Oh, I just pray that no other family has to experience what we had to experience. And I know that, it's a small number, I know, compared to a bulk. But that small number could be your child, your daughter, your son, grandchild, nephew, niece. In that situation, I do not pray that on my worst enemy. There's nothing like the loss of a child. Thank you all.
Thank you very much for the comment. Frankie Milley again, from Meningitis Angels.
Hi, I am Frankie Milley and the National Director of Meningitis Angels. What most people don't realize is that 35 to 40% of our angel network are pneumococcal families. And I know you covered the 10% death rate, and I did see that you covered some of the disabilities, but I can tell you that yes, maybe 10% die, but there's a lot of kids out there within our network, hundreds, that have serious after effects of pneumococcal meningitis. Serious, they're blind, they're deaf, they have forms of what is diagnosed as autism syndrome. They have seizure disorders so horrible that you can't even imagine. One of my moms told me that her greatest fear, 8 years after pneumococcal, is she will walk in the room and her baby will be dead, her child will be dead. These families, some of these kids have up to 10, 15, 20 seizures a day. It's nonstop. These kids are 24-hour a day, 7-day-a-week care. Now, I've testified, I think, once in 12 years of coming to ACIP meetings on pneumococcal. And you know why I haven't? Because you guys always do the right thing. I believe that you always do the right thing, or you try your best to do the right thing in all cases. But we have a saying in Texas, if it ain't broke, don't fix it. And that's kind of how I feel about this. We have had wonderful success with pneumococcal vaccine, just the way it is. So let's don't fix it. It ain't broke. But if we delete that 4th dose, it might be broke. And I want to be able to go back in the months ahead and assure my families that are dealing with children that live horrible lives with these kids that are seriously disabled from pneumococcal meningitis, that you guys are going to do the right thing. And one of the things Josh didn't say to you, they're expecting another baby. They have a 2-year-old who's had 4 doses of Prevnar, so they feel safe. But they're expecting a baby in the spring, and he is horrified that you guys may delete that 4th dose, and he may have to go through this once again. So again, I want to say to all of you, thank you so much for the work and the dedication that you guys do. I know you're going to do the right thing. I know that. As for meningococcal, we'll take that up another day. Thank you.
Thank you very much. And then Shannon Duffy Peterson.
My name is Shannon Duffy Peterson, and I am here on behalf of PKids, but I am a parent. And I'm going to read it because this is very difficult. Our children are worth every penny. A life-changing event, one involving our children, will make any parent regret what they could have or should have done. I have firsthand experience of this. I held my daughter Abigail in my arms while she died of one of the world's biggest vaccine-preventable killers of children, pneumococcal disease. Abigail was just shy of her 6th birthday. I'm a parent of 4 children, a business owner, and through PKids, an advocate for immunization and keeping children healthy. My younger children are at home in Sleepy Eye, Minnesota, and my oldest daughter, Abigail, is up in heaven with her grandparents. In 2001, my 5-year-old daughter became a statistic when she died of vaccine-preventable disease. Abigail became infected with pneumococcal bacteria during the 2001 influenza vaccine shortage. She was not vaccinated for either disease. When our children were born, my husband, Dwayne, and I were adamant about vaccinating our children. We wanted our children to be protected against everything, and we wanted healthy children. At that time, we had a pediatrician who did not push vaccinations and did not recommend the most recent vaccines available. Consequently, my children did not have their chickenpox, flu, or pneumococcal vaccinations. February 18, 2001 began as a normal Sunday. We took the children to Sunday school, went to church together, played throughout the day, danced with them to music, and then relaxed with them before bedtime by playing a board game. Abigail said she wasn't feeling well and had a headache. We had her lie down and took her temperature. It was 101.5 and gave her some Motrin. She started to vomit up the medicine. We thought she had the flu. We thought this was strange because she had had the same illness and a sinus infection 2 weeks earlier, but she was in kindergarten and we knew that there were many germs that the kids were passing around. We became alarmed when a rash developed all over her body that we had never seen before, but we suspected it to be a high fever rash. I called the emergency room and was told it was a flu going around with high fever, vomiting, and diarrhea, and to just treat the fever alternately with Motrin, Tylenol, and a tepid bath. Abigail was tired and we put her to bed, planning on to check on her quite frequently, but hoping that she would sleep off the flu. Throughout the night, we kept changing her bedding and bathing her to break the fever, even though she seemed pretty lethargic, and ended up sleeping with her to comfort her. We awoke later to her crying, "Mommy," as she had fallen out of bed while attempting to make it to the bathroom. It was then while cleaning her up that my husband noticed the tremendous blotches on her skin and said, "This is not normal. We have to get her to the emergency room right away." We woke up our little boy, got them both in the truck, and drove as fast as we could, 21 miles to New Ulm, Minnesota, and called the hospital on the way to say we were coming and prayed for the best. I sat in the back with the children, comforting Abigail, and when she said to me, "Mommy, I hurt so bad all over," I assured her it was from the sickness and held her in my arms the best that I could while we were all buckled up. Those were the last words I would ever hear from my beautiful little girl. She died in my arms while we were driving. When we arrived at the hospital, they called a code blue and attempted for 1 hour to revive her. Her heart never started, and they were breathing for her. She was pronounced dead at 7:20, Monday, February 19th. Our hearts broke that day as our son, Abigail's little brother, witnessed all of this, and we had to tell them that his playmate, his bedtime companion, had died, and there was nothing Mommy and Daddy or the doctors could do to save her. It doesn't end there, though. 2 hours later, after we arrived home from saying goodbye to our firstborn, our son started to experience some of the same symptoms as his sister, and I rushed him to the clinic. They got us in immediately and started running tests. While we were waiting for results, Samuel, our son, started to vomit. I couldn't believe this was happening all over again and was holding him on the floor of the doctor's office when our pediatrician came in with Abby's preliminary autopsy results stating that she had overwhelming sepsis caused by streptococcus pneumonia, congenital asplenia, and hemorrhagic adrenal glands. I thought I would lose both my children that day. While my daughter's death happened quite quickly, and I wasn't able to save her by rushing her to the hospital, I was able to save my son by hospitalizing him directly after her death for 2 days, as he was extremely sick. With hospitalization and medication, he recovered enough to be released from the hospital in time to attend his sister's funeral. My world changed in those life-altering 3 days. I now understand the importance of vaccines and how children's lives depend on them. I'm asking all parents to make sure kids are kept healthy and vaccinate them. And if we do this, we'll save lives. It's our responsibility as parents and medical professionals to protect our children and to protect all children. It's not okay, in my opinion, to reduce the number of pneumococcal conjugate doses children get based on cost, or even the fact that we have, thankfully, a full immunization schedule. We listened to our pediatrician, we didn't vaccinate, and we lost our Abigail, and we almost lost our son, Samuel. I'm sure all of you follow the recommended vaccine schedule. If a primary dose of the pneumococcal vaccine is removed, it will save some dollars and mean one less vaccination for our kids, but it will also mean more kids will die, more kids will be hospitalized, and more kids will be in pain. If you follow such a schedule and your child is hospitalized, or if you should lose your child to this cost-saving measure, well, that would be unthinkable. It's not acceptable to risk your family or mine or anyone else's. Why would we ever choose to increase infection when we can decrease the number of cases through simple vaccination? Thank you.
I thank our public commenters for sharing very, very difficult stories there.